Good morning. We want to go ahead and get started, please. Before we welcome everybody this morning, I'd like to open in prayer very quickly. Carmen, Representative Rice.
Thank you. Dear Heavenly Father, I thank you for this day. I thank you for each person here and the hospitality we have already received and the blessing of the conversations already had. I pray that you would bless this meeting that we have as we work together to find solutions on a problem very dear to our hearts, and that you would open our eyes and you would open the door and show us the way on each and everything that we can do. In Jesus' name, amen.
Well, welcome everybody. Thank you so much for being here today. I want to thank my colleagues as well, and in a moment I'm going to have them introduce themselves. And especially I want to thank Leo, Mr. Leo Chansey, our policy analyst, who has put this all together. Thank you so much, Leo. We are excited about being at this meeting today at Mercer University School of Medicine. And what a wonderful campus. I saw the backside of this building first, if anybody else did that. But no, seriously, it's a beautiful campus, and I'm so thankful for you all inviting us to be a part of this. Our presenters have put so much time and care into these presentations, and I know I'm looking forward to what they're going to bring us and the recommendations that they're going to have. And if you don't mind at this moment, if you would introduce yourselves, and then presenters, when you go up, if you would introduce yourselves before you speak. Thank you.
Am I live? Okay. Good morning. I'm Angie Osteen. I represent District 169, which is Coffee, Irwin, Turner, and Tift.
Good morning. I'm Lisa Hagan. I represent House District 156, which is 6 counties just to our east.
John Odom, Savannah.
Okay, I'm Jean Sumner. I'm the Dean at the School of Medicine here. Thank you.
Hi, I'm Angie Gerges. I am the Medical Director at Georgia Southern University Health Services and Ogeechee Area Hospice in Statesboro, Georgia.
Good morning. My name is Carmen Rice. I represent District 139, which is Columbus and Muskogee County.
Gary Richardson, District 125, half of Columbia County and half of McDuffie.
Good morning. I'm Butch Parrish, represent District 158, Emanuel, Trutland, Candler, and a portion of Bullitt County. Glad to be here.
Thank you so much. And we'll go ahead and get started, Dr. Sumner.
While he's fixing that, good morning and welcome to Mercer. Mercer has been in Georgia since 1833, so if you've never been here, we're glad you made it, so we're welcome. If you notice around the campus, there are flags on every light pole that say Mercer majors in changing the world. They mean that, and students here focus on not only a good education, but the opportunity to serve our state and our world. At the School of Medicine, we were created as a public-private partnership with the state of Georgia. We received some state funding for our mission, which is to educate young people or physicians for rural, underserved Georgia. We take that mission very seriously. I refer to it with the students on a regular basis as a very sacred trust. Our rural Georgia needs our help. They need physicians, and so we try to not only pick the right students, we try to find students who really care as much as we do about rural Georgia. So thank you for letting me speak today and to be on the committee. I think it's really important to understand the path that young people take to get in medical school, and sometimes you forget it's a complicated path, and it actually starts very early in life. Pathways, they used to be called pipelines, they've changed it to pathways now, are important, and they've been shown to work. So because young people in rural communities often don't have the access or the exposure to medicine like individuals in larger communities, we have a department that works very seriously with rural communities. We have a number of events, and I'll show you how they are, but the early involvement in career choices matters. Through the years, many of you have been invited to career days at high schools or elementary schools, and you think, this doesn't matter. It actually does matter. So show up and talk about what you do, because it inspires those young people. But physicians are notorious for not showing up, unless you have a child or a grandchild in that class, and you go. But we really should speak about what we do, because young people listen. But really by the 8th or 9th year of their education, that's when they start forming their ideas of what they could do. So you need an effective strategy. This is our map. The orange dots on there are the places that we have pathway programs, so we've touched lives in those counties. Through the work that Mercer does and through the Innovation Center, we actually have work going on in every county. We focus on the 120 rural counties, but during COVID, we had camps that we did, but we started a virtual camp. And our thought was, after COVID, we'll forget that thing. I didn't like the virtual camp. I thought it was a bad idea, and I was proved wrong. When we tried to cancel it, we had an uproar. We send boxes to young people that register. It fills up in about 2 days. We have over 100 participants generally. Our students and faculty have run that camp. They teach those kids about cases and what you do. This year the topic was kidneys and how to protect your kidneys and what affects the kidneys. We send them fake urine and they test it with the medical student or the faculty guiding them. But they get lectures that are appropriate for their age on physiology and anatomy and things that harm. And that is an extremely well-received camp. People look for it. The box we send them includes various tools. We've sent pulse oximeters, glucometers, stethoscopes, and we show them how to use them. We also send stitching pads that you can show up and learn to tie a suture. Dr. Odom, I'm going to have to put you on next year's schedule so you can help us with the suturing. But those kids are so proud of their work. They may not be physicians, but they're more likely to look at healthcare as an option. And the parents love it. We get great reviews for the parents. But think about the path to college. And think about the path to medical school. There you go. These are the requirements. The top 4 bullets are the requirements for almost every medical school in America. Now, we work with undergraduate advisors as well to help them know. And Dr. Rick McCann, Rick, stand up just a second. Okay, I'm not going to pick on you much. Okay, thanks. If you have interest in how to get here, Rick McCann's our admissions dean. He also is an accomplished biochemist who likes data. And about 10 years ago, we drug him out of his lab to look at the data for the last 40 years on who could pass and who did well. And surprisingly, it's not what you might think. We still take the MedCat. We still take grade point averages. We still focus on that. But there are ways to identify students who would be successful other than just those metrics, and Dr. McCann and his team do a great job. These are the courses that they must have to come to any medical school. Now, it doesn't really matter what they major in. If they love history and can get these courses in and get a foundation, they'll do fine. We love communicators or people who know public speaking or communication. And I think every medical school looks for some diversity in their group. And then we look for service, a service-minded individual, somebody who has a committed volunteer history. They don't have to do research, but they have to be engaged with causes in their community. And then also that they communicate, and at Mercer, we eliminate those that are clearly not mission compliant and won't be if we can. I mean, we care about our mission very much. The admission process is rigorous. goes to the American Medical College Admission Service. Every medical school does that. If you go on that website, you'll find the requirements for every medical school in America. And if you don't meet those requirements, it will block you. It will tell you what's wrong, and then you have to include all this information on those sites. And then we look at work experience. One factor we track is that if you had a job in college and made good grades, you've got discipline, and you need discipline and commitment in medical school. And then the others I mentioned. And so this is sort of the path. After they're accepted, year one is biomedical sciences and clinical skills. We pride ourselves on teaching young people to do physical exam, being able to talk to a patient and examine a patient. And we also send them to rural communities in the first year for 2 weeks, and they study population health as well in the first year. Same in the second year. The third year in all medical schools is the clerkship years. So they go through the OB, pediatrics, internal medicine, family medicine. It's often the time that they solidify their desire to be what they want to be, because they have a good experience or they have a mentor and they see the opportunity. But in the third year, they have an opportunity to go out and work with a really good rural doctor who's happy and serving their community, and it really impacts them. And then year four is a busy year for them. They get to do a lot of electives. There are some requirements, but they start to apply for match. And match is a stressful time for them. They have to get a letter from the Student Affairs Dean. It's called the Dean's Letter, but it is an honest assessment of their performance, their professionalism, their experiences in medical school. Fortunately, we've been very fortunate to have an excellent match. I think we were 99.3 this year. One student dropped out the day before and decided he wanted to wait a year, which is fine. But there are years we have 100% match day one. So, and I think that Mercer students can talk to people, examine people, and come up with a differential diagnosis. So that's great. We match all over the country. Our goal is for them to match in Georgia. So we lead the state in the percentage of our graduates that stay in Georgia. We're about 44%. And I think you'll see that number go up when we open more residencies, and you'll hear about some of those today. Residency for an internist is 3 years of supervised medicine. You have the opportunity each year to gain more independence and skills. You pass an in-service exam each year to proceed, along with other factors. Step 3 is what you usually take toward the end of your first year. After year 1, you take step 1. After year 2 in medical school, you take step 1. After year 3, you take step 2. After the first year of residency, you can take step 3. Some people delay it. And then when you finish your residency to be board certified, you have to take a specialty exam. And then you have to do a maintenance of certification. Internal medicine is required to take that exam every 10 years. You can take it every 5 years if you choose to on a different track. But you also have to do other work to prove you're certified. In your folder, if you would, there's some information. One is a little magazine that we created for you to show you the path to medical school. It's what these slides show. It talks about how to get here and things that go on. Another is a map that we use for all our special programs. If you're on a scholarship at Mercer, you get to choose the county you go to that's in orange. We use rural counties when they are, there are counties in this state that are rural. There are a few that are rural and are not underserved. We look for rural, underserved counties. Then there's also a paper from Dr. McCann that shows what admissions requires. And then if you think about our admissions, we only accept Georgians. I put a slide, I didn't make it a slide, of where our students are from. Now, I left Atlanta blank because we do have about 30% of the students from Metro Atlanta. But these are the rural students that have been admitted to Mercer and been successful. So this is, since we changed the way we admit that group. I'm delighted today to really share with you some expertise from people in the trenches who've done the work to make this a better state in rural Georgia and understand graduate medical education. Who wants to go first? You? Laura, are you going to go first? Okay. Do you have a preference? Do you have a preference? Who goes first? Dr. Laura Denton is a faculty member, but she also does lots of things, and you have her bio, so we're going to disperse with bios if you don't mind, and you can read about her. She's famous. So.
Not very famous. About the most famous thing I did was go to Mercer to medical school and become acquainted and be Dr. Sumner's student. So how do I get to my slides? Oh, thank you. Okay. My slides are very informal. They're not as nice as Dr. Sumner's, but she suggested I make slides to keep me on track because she knows that I like to talk a lot about medicine and what I do, and she was afraid I'd get off on a tangent, I'm sure. So, thank you. I have been a very happy internist for my entire career. I graduated from my residency in 1992, moved to Savannah in 1995, and I've been there ever since, teaching students and residents and an occasional cardiology fellow that they couldn't find a place for him to go. So I've had a really fun and enriching career in education. So I thought this was an appropriate title for our mission for the committee because we're trying to determine how we can get more internal medicine physicians to small communities in Georgia. We know that we don't have as many internal medicine physicians as we used to, as many general internists as we used to, and we certainly do not have as many in rural areas that we need. So, oh, doctor, where art thou? Why fewer students? And I wanted to say thank you for the committee for what you're doing. This is all voluntary, I know, and I appreciate getting to speak because anytime I can talk about internal medicine or serving others, I am delighted. So, I wanted to go over a few definitions because it's very difficult to understand what different doctors do and what their role is. So, easy, outpatient general internist, this is someone, Dean Sumner alluded to someone that does 3 years, an internist does 3 years of training, and then they can go out and practice on their own. The outpatient general internist is probably the doctor that you see. Family medicine would be the same, but it's somebody that you go to see for your routine annual physical. A hospitalist is a physician that only does inpatient medicine. They only take care of patients that are admitted for illnesses. They do not usually have a practice outside of medicine. A specialist, and if you have a cardiologist or a gastroenterologist that did your colonoscopy, that is a person that has trained in internal medicine for 3 years and then gone on to do a fellowship. And these are the fellowships: cardiology, gastroenterology, endocrinology, rheumatology, infectious disease, pulmonary critical care. So you see there are a lot of options, lots and lots of options. And this is just the basic list of fellowships. There's other things you can do too. And there are more things invented all the time that you can combine. And then we have this small little traditional internist. This person really doesn't exist anymore. Very, very seldom do you see somebody that actually gets up, goes to the hospital, rounds on their patients, and then goes back to their office, and then maybe goes back to the hospital that afternoon. That just doesn't exist anymore. Every now and then you'll see somebody do that, but generally their office is within the hospital, because a long while back, maybe 30 years ago, physicians figured out that for the reimbursement that they got for seeing one patient in the hospital, they could see 3, 4, 5 patients in their office during that hour, the commute, and actually do better. And also, hospitalists were invented about 1992, and I'll tell you a little bit more about that. But traditional internists are very rare. We do have one resident that's graduating in 2026 that is going to do traditional medicine because she's going to a small hospital, one of the very few hospitals that I've heard of in Georgia that does not have a hospitalist program yet. So this is the emergence of hospitalists. In my opinion, and some of the other internists in the room may have similar opinions, but my opinion is that when we began to divide graduating general internists into outpatient and inpatient physicians, that is when the real shortage of internists in the community started. So the competition, and this is what I wanted to tell you about that. So when you're trying to find an internist to come to your community in Georgia, in 1992, that's when I graduated from my residency, and I had 5 very reasonable and viable opportunities. One was in St. Simon's. There were 2 in Atlanta, one in my residency program with Dr. Baxter. Some of you know Dr. Baxter. He asked me to join his practice. There was a nephrologist that was looking for an internist. I ended up working in an urgent care center, multi-specialty family practice down in Fayetteville, Georgia with the Sams family. That's the job I ended up taking. But I was called, I worked at DeKalb Medical Center in Atlanta, and a very intriguing opportunity. I worked in their urgent care center. Somebody called me, and this was 1992, and they said, we have too many unassigned patients in our ER. We have a lot of people coming in now that don't have insurance. We have to take care of these people. We're developing this program where doctors work 7 a.m. to 7 p.m. for 5 days. They have 5 days off, and then they work 7 p.m. to 7 a.m., and they have 5 days off. And I actually interviewed for this job. It was a great job. I chose the other job, but that was the first I had heard of hospital medicine, so 1992. Fast forward to 2013, I did a little AMA study, and at that time, every graduate in internal medicine had 11 to 13 viable options, things that they could take. A job in Dublin, Georgia, a job in Jacksonville, Florida, a job in Savannah, viable jobs, jobs that they could just sign and have a career. This past year, when I pulled the data from the National Residency Match and from ACGME, 100 offers, 20 are viable. So do you see the competition we have trying to find internal medicine doctors to go to communities, especially to rural communities? This data is really, really compelling. So if you look at how, and I only want you to look, let's see if this is a pointer. I only want you to look at this. But right around the pandemic, this is training data. When you look at all internal medicine residents that graduated between about 2017 to about 2021, 67% of those residents chose a fellowship. 15% became hospitalist. 9% went into general internal medicine. Now, almost 90% of our residents, when they graduate, are doing a subspecialty. So we've got that little 10% group of residents in general medicine, and many, many, many of them do hospital medicine, and I'm going to show you why. So when we asked residents why they didn't like internal medicine and why they weren't going into that, this little survey, and Dr. Sumner, this is from Family Feud. I thought of what you told me. There were 1,177 students that responded, 11 medical schools, 23, now this is everybody, so this is all medical students. They can go into pediatrics, OBGYN, they can go into whatever they want to. But 23% of those chose internal medicine. Remember, they're wanting to be gastroenterologists and cardiologists and things like that. And only 2% of that entire group wanted to be general medicine doctors. And this is what they said: less pay than specialists, okay? Less controllable lifestyle. Predictable lifestyle is #1 on these young people's list. They work 13% less hours than a physician 20 years ago. That's the data. The electronic medical record, which you might hear as the electronic health record, has the 1 to 2 rule. Does anybody know what the 1 to 2 rule is? For every 1 hour of patient care, you have 2 hours of paperwork, filing, calls, prescriptions that it equals to. So resident students, they're very aware of that 1 to 2 rule. What about work equals home? So the boundary, the being in the grocery store and the patient last week that you saw that's telling you about their stat and making them have constipation and they want a new drug, and could you walk over to the pharmacy and please do that right now because they don't want to take that one anymore. It happens in these small communities. And so people want to know that they have boundaries, especially with family life. Everybody talks about this. I don't think any medical students, residents, and probably some attendings even understand this, but it's viewed as bad and is talked about. And so, some residents say, well, I don't know if I can do that because there's decreasing Medicare reimbursement. I'm sure they don't know what they're talking about, but we do. The older physicians, we certainly understand this and how it affects choices for residency. There's debt, there's longer work hours perceived if you work in an outpatient practice. And then I want to say one more little thing about this. On the EMR rule, does anybody know the term pajama time? So my son, who's a medical student, called me and said, Mom, what is pajama time? And I said, well, I will tell you, it is not kindergarten wearing your pajamas to school. It's not that anymore. If you Google pajama time, this is what you see. It's an actual term. This is what comes up when you Google pajama time. It's an actual term to describe the time that physicians sit at home at night with their family, or maybe not with their family, but they do 2 to 3 hours of charting at night. And this is general internist. This is a huge deterrent to our students right now, pajama time. And there are actually been articles, this was in JAMA, how to help physicians cut pajama time and have more great days. It's a thing. So this is the real problem that we have. Remember I said that general internal medicine was divided into inpatient and outpatient doctors? This is one of the biggest reasons. When you look at this slide, the hospitalist is in the hospital. They have short-term relationships with patients. They usually work anywhere from an 8 to a 12-hour shift. They take care of the patient that has the gallbladder, like the 35-year-old that comes in with appendicitis that doesn't really have a doctor would go to the hospitalist service. Okay, that's who they would take care of. And then look at this. Can you see their average pay? And what I didn't say is they have a predictable schedule and they generally work 26 weeks per year. Okay. The internist, like general internists like Dr. Sumner, Dr. Hanna, myself, we usually work in clinics for private offices. We incur overhead. These guys don't have any overhead, okay? We incur overhead. We have faculty and staff, or staff that we want to pay well, give insurance to, take care of. We take care of the patients that have long-term chronic management, diabetes, hypertension, just day in and day out, chronic problems. We work a lot of weekdays and we have more regular hours, but the hours tend to extend more. They bleed into pajama time. And then the average pay is vastly different from this. 26 weeks, $371 without moonlighting. The internist, 47 weeks, 48 weeks, maybe if you've got a really nice employer, 46 weeks. And this is what you get paid. So this is a huge problem for graduating internists. What are you going to choose when you see that? So this is just reiterating it. But again, they're way down here. The gastroenterologist is way up here, the cardiologist. So, and not all specialties, rheumatologists, endocrinologists, there are other specialties that make much less and are right in this area. But this is very, very important to somebody that has a lot of school debt, and so they choose these specialties. So what are they saying? What are the problems? What are our students saying right now? And these are just some direct quotes, but it's a lot of debt. You get out of school with debt, and then you make $65,000 for the next 3 years as a resident. At the very top of my list of stressors is finances. I owe a little over $270. We see this. I don't think I'm going to be able to pay that back on a primary care salary. I'm looking at something where I can do procedures. I'll be moving my family with 2 young children, so schools and safe neighborhoods are important. Would be a real blessing if my spouse didn't have to work so that they could take care of the children. And then I want a very controlled lifestyle. My grandfather was a rural family physician. We all know one of those from our past, and I can't do that. So the bottom line right now in internal medicine, our subspecialty is the top choice. The hospitalists are a significant portion of the divide in internal medicine. There's a huge outpatient decline, as we know, and there's a shift in career trends. People want to be surgicalists, hospitalists. They want to be OBs that just work shifts. They want to job share. It's all out there. So what are the pitfalls when you're trying to start a rural residency? Dr. Sumner wanted me to talk about that too, because we've been very fortunate. Last week we found out in Coffee County, and Ms. Lewis, our CEO, is here, that we are accredited now for a 15 resident internal medicine program. So Dean Sumner asked me if I would talk a little bit about what's hard about starting a rural residency as opposed to one like we have in Savannah, where we have a level 1 tertiary, level 1 center where we have all the specialists that we need. And I think probably the biggest thing was the inability to meet ACGME requirements, okay, because across the nation, they have very stringent requirements to be an accredited program, meaning you got to have a certain number of specialists, you've got to have an infrastructure, you've got to have call rooms, you've got to have a place for a young resident to breastfeed if they need. There's all these things that small community hospitals don't have. So that was hard in the beginning. Lack of board certified physicians. This small community that I'm going to has excellent, excellent physicians that have been working for the last 30 years. They do a great job taking care of patients. They are not board certified because they haven't had time to keep their boards up. They've just been busy. They're in a very secure job setting. We have to change that. More people have to keep up their board certification. It's hard for us to have scholarly activity in a place where doctors are so busy. So ACGME requires that all your physicians on your staff do scholarly activity. That's just not possible in a small place. So that was something we had to work around. Also, the next big thing that we're about to go over the hurdle is attracting Georgia and qualified residents to our program. We want to train people from Georgia. We also have to have schools, worship centers, cultural opportunities for people that maybe aren't from a rural community. So we've got to think about our cultural sensitivity towards people that are going to apply to our program. And then the biggest pitfall for everybody is it's expensive, 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 and you don't get money back for quite some time. So it's a huge outlay of money for the state, for the hospital, for the community, and we have to reap that money back. It's going to be a while. So going back to the definitions, I just wanted to say I had to have one of these in Douglas, Georgia. And you can imagine, we don't have this in Savannah, Georgia. We don't have the physicians we need in Savannah, Georgia. So ACGME says you start a program, you got to have this. So you have to come up with some solution to having all these specialists because they all have to be a part of your program. So this is what we know, and this is what we can walk away with. 50% of residents stay in the state they're trained. This is, I don't even have to cite this anymore because it's such well-known knowledge. If you put a resident in a rural community for several of their rotations, they're much more likely to practice in a rural area. So getting students, Dean Sumner gets students to these rural hospitals, these rural communities, those students are more likely to pick a rural community to stay in. This is vastly different in a small community. Physicians are still valued and respected members of the community. Nobody calls you a provider, very seldom, and you actually have respect. It's just not the same with corporate medicine. So this is a wonderful difference of being in a rural community that residents and students notice when they're there, when they're rotating with you. And so these are my citations here, but rural exposure during a family medicine residency training is associated with a 5 to 6-fold increase in subsequent rural practice. So, but in family medicine, less than 10% of graduates experience any rural training during their residencies. So you must credit Dean Sumner because she is getting our medical students from Mercer all over the state to rural communities right now, including, I'm sure they'll be in Douglas soon, but they go to Valdosta, they're about to go to Tanner Medical Center, and that we know makes a difference. So we need more rural tracks. We got to think about some tax credits for residents that they understand. Maybe there's a stipend for going to a rural residency program. That is something, because as you can see, money talks. When you look at hospitalists versus general, they need money to entice them. And then loan repayment's important once you graduate and get your job, but benefits and stipends are more important while they're in their residency, something to think about. And I just want to say thank you to everybody here. Thank you for your time. And Ms. Lewis, myself, Dr. Hannah, and I know Dean Sumner, we want to know what we can do to help, because we will help you. Thank you.
Need the same help, if you please. Thank you so much. I'm Vicki Lewis. I'm the president and CEO of Coffee Regional Medical Center in Douglas, Georgia. And I am the lucky person that gets to work with Dr. Laura Denton, and who is a very happy colleague of Dr. Jean Sumner, and I'm going to talk a little bit about that. I'm going to share with you the journey, thank you, that Coffee Regional Medical Center has been on in earnest since 2022. We had talked about things before that, but we've really been on this journey in earnest since 2022. When I came on board in 2014, I've been at Coffee Regional Medical Center for about 11 years, we did a medical staff development plan. And we looked at the age of our physicians, we looked at the population in our community, the chronic disease, the reasons people were coming to the hospital, the reasons people were dying, frankly, and came up with a significant need. It was almost overwhelming. At that point, we were in dire need of 22 primary care physicians. So fast forward to 2022, we were in dire need of 23 primary care physicians. And that is despite the fact that we had tripled the size of our medical staff. So we had added many, many physicians, and some of those were EICU physicians and tele, but we had not solved the problem of primary care. And so we really took a hard look at, what it felt like a little bit to be, a headbanger, if you will, our frustration over our multi-year lack of progress. So, and we also took a look at our medical staff not getting any younger, frankly. And as Laura pointed out, key specialties, not only internal medicine, but cardiology, neurology, gastroenterology, endocrinology, those specialties were also not available to us. And if they were typically a drive away. And again, this is despite everything that we had done to try to remedy the shortage. The other thing that is a dose of reality for us, Coffee County has a population of just over 44,000. The city has 11,000. And we rank 99th out of the 159 counties in Georgia in overall health outcomes. And that's daunting. That's very difficult. Believe it or not, in the 11 years that I've been there, we've come up from about 130 to 99. So that's huge progress, and that's in large part thanks to our medical staff and some of the things that we've been able to do in expanding our service lines. So we have grown service lines, we have taken care of more people, we have a bring-it-home strategy for recruiting physicians, and we have a excellent care close to home strategy for our patients. but we were still, very, very much lacking in the care we needed to improve the overall health. So we took a look at some of the things that we thought might improve those health outcomes. And primary care came up every time as number one on the list. We knew that if we had enough primary care physicians to care for our patients, keep them well, manage their chronic diseases, that we absolutely could save money. We could reduce our admissions, we could reduce the acuity of our admissions, and we could keep our population healthy. We also knew that we could, if a patient did have to come to the hospital, that we could reduce the length of stay and their readmissions. Obviously, this is not only, Coffee Regional Medical Center and Douglas, Georgia, but it's a nationwide trend that those who live in rural communities simply are more ill. They have more chronic diseases. They have more difficulty in managing things that are more available from a resource standpoint in large communities. We have a high degree of obesity. We have a high degree of diabetes. We still have a high percentage of our community who smoke. So we've made some inroads there, some of those I described, but we are still really facing those challenges. So we kind of took a step back and said, is GME a solution? Is having our own residency program and being able to train our own primary care physicians a solution? Could we succeed? And we spent a lot of time really looking at that. We have many priorities. We have many heavy lifts in a community hospital on a daily basis. Making a bottom line, making sure we have the equipment that we need, making sure that we keep our facility up to date. And then, was it a fit with our mission and purpose? Could we make this a financial priority? You throw things like Hurricane Helene on a community like Douglas, Georgia, as well as all of these other challenges. And we wanted to make sure of all the heavy lifts that Coffee Regional Medical Center had to make, that this was one of the right ones to make. So this is just another thing that we looked at in 2022. This is a map of all the teaching programs in Georgia. And you can see in the middle of the circle is Douglas, Georgia. There's a pretty big GME desert in South Georgia. And so this was a very helpful look for us to really say, hey, no wonder we're having so much difficulty recruiting and physicians and recruiting specialists, is we're not training them close by. And they get enticed by the Savannahs or the Macons or the Atlantas and go there. So, and obviously Chairman Parrish and Chairman Hatchett are two of the individuals who helped us with some of these things. We sought the advice of the Georgia Hospital Association and our legislators about some funding sources. We really had to take a look at this early on. Georgia Strong, some of the potential changes in Medicaid and Medicare reimbursement, HRSA grants, the Georgia state budget opportunities for line item appropriations, and the State Office of Rural Health were all things that legislators suggested to us as potential opportunities. We also looked to Dr. Sumner. I want to give a big shout out to Dr. Sumner. She really helped us immensely. She encouraged us. She told us over and over again, you're going to position yourself in a way that you've not been positioned before. You're going to realize so many benefits from being a training program, and I know that the community and your patients are going to benefit from that. She also gave us support in some things that small rural communities simply don't have. We do not have a medical library. As Dr. Denton described, we don't have a lot of opportunity for scholarly activities. Not a lot of our physicians are doing research. And also we needed faculty, frankly. We had, as Dr. Denton described, some fantastic physicians who had been practicing things like internal medicine for a long time, but had either let their board certifications lapse or had not sought those in the first place. So that was a big challenge. And most of all, Dr. Sumner said, you can do this. I have faith in you. And that was extremely helpful to us and continues to be helpful to this day. We also then had to work with our auditors. So we used Forbes Mazars as our auditors, and they came in and did a deep, deep dive into Coffee Regional Medical Center's finances. They knew, because they've been our auditors for 3 years, some of the difficulties that we had gone through. They very well understood our payer mix. They knew where the dollars were coming from, and they knew the potential expense that was going to be created by the residency program. Very early on, they said to us, if you can do this and get through the first 5 years, you can be successful financially. And I will tell you that I had to really do a lot of soul searching. We really, our financial team at the hospital is fantastic. We have a deep team, and we really took a good hard look at it. We could not jeopardize our mission. We simply could not jeopardize Coffee Regional Medical Center's ability to care for our community and keep the services open that our community so needed with the residency program. And so we were determined not to do that, but do it in a way that if we could possibly manage, would at least begin to break even relatively soon after we opened the program. I will tell you that we're a little nervous about that, frankly, as I stand here. We have received a lot of dollars from both the line item appropriations in the Georgia budget, as well as the State Office of Rural Health, and some of the dollars that we've gotten through the state in general. So we have received so far about $2.2 million in appropriations. That doesn't mean we've drawn down on that, obviously, because we just learned last Thursday at 4 p.m. that the program was approved. But some of those dollars are there. That $2.2 million will get us through probably the first 18 months of the program. And you'll see that I've got some asterisks up here on Georgia Strong, the Medicaid reimbursement, and the CMS program. And my plea to you today is to really gain an understanding of the need for teaching hospitals to have the timely recognition of these costs. The way that the funding works is it's based on hospital cost reports. And currently, those cost reports are looked at as a 2-year look back. So we will begin training residents in July of 2026. Our first, and so in 2026, if you look at our cost report, the residents will be, even though we'll have 5 of them, will come out as 2.5, because we'll have them for 6 months. 2027 will be the first year that we will have 5 residents. And the 2029 calendar year, governmental calendar year, is when that will first be looked at. So we have to get ourselves from 2026 to 2029 before that look back on Coffee Regional Medical's cost report is going to result in a pickup in reimbursement in Medicare and Medicaid. That's a heavy lift. That's a long way from here to now. So I stand before you a very happy and excited person that this program has been approved, and I know it's going to make a difference in our community, and I am very grateful for many of you in this room and your support. But we have simply got to figure out a way to get from July of 2026 to 2029 and not jeopardize those essential services. One of the really helpful things, so thank you for your consideration of that. One of the really helpful things we did is we visited some other community hospitals who had well-established programs. St. Francis in Columbus and the Houston Medical Center in Warner Robins were 2 of the facilities that we visited. One had internal medicine, one had family practice. That was enlightening, to say the very least. They were candid with us. They helped us understand how they launched the program. And more importantly, they helped us understand the dramatic changes that their hospitals had undergone because they got the program up and running. We also had then some non-financial hurdles that we had to get over, and the most significant of those was GME leadership. So in November of 2024, when Dr. Laura Denton said yes to our offer of being our residency program director, there were a lot of high-fiving in the hallways of Coffee Regional. We are forever grateful that she joined us. Again, we knew that being successful had a lot of advantages. We just needed to get our program funded and launched. So this is a timeline that I wanted to share with you that, again, we started in earnest in 2022, as I said on the previous slide, but we really then in 23 secured our board approval. They passed resolutions, made a commitment. We appointed an institutional coordinator. This is a master's prepared registered nurse that Dr. Denton works with. She's awesome. She has unending energy. She needed help and an understanding of what the program was. Dr. Denton helped her with that. We seated our internal steering committee, our GME committee. We did engage a consultant. We spent a little bit of money, not only with our auditors, but with a consultant. And then we also appointed a DIO, and at that time, a program director who was board certified in family medicine. Again, we were naive in this process, and looking at our community and looking at the healthcare needs there, we believed that family medicine was the best opportunity for us. And so we submitted an institutional application in October of 2023, and then pretty soon after that, we were waiting, and we submitted the application in June of 2023, I apologize. And pretty soon after we submitted the application, we really started, with the help of the consultant and some of our physicians, to understand that we had to switch to internal medicine. We could not support with pediatric volumes, among other things, the family medicine program. And I think Dr. Denton did a super job of describing why internal medicine made more sense for us. It made more sense because we needed to retain internal medicine physicians because of the acuity and chronic disease management of our patients, but also because it was our hope, and it remains our desire, that some of those physicians will train in our program, go off to be gastroenterologists and cardiologists, and come back to the program. We really believe that we can make that sticky. So we changed to an internal medicine program and then submitted that application in February of 2024. So we received institutional approval at the end of 2024 in the fall, and then submitted the program approval. We had a virtual site visit in April of 2024, and the ACGME, you wait between April and September. Being on pins and needles doesn't quite describe that. And the approval was withheld. And the reason that our initial approval was withheld was because of the lack of experience of our program director. So we had a dedicated physician who actually was our chief medical officer, but he did not have enough teaching experience. And I think that was a very fair assessment by the ACGME. So with, again, Dr. Sumner's help, we were able to recruit Dr. Denton. Dr. Denton is a master physician with the American College of Physicians. She has more than 30 years teaching experience. It was gasoline in our engine. It was a huge boost to just our outlook about the program and what we really believed that we could accomplish. So in February of this year, we submitted a second application, had a site visit in person this time in April, and then sat on pins and needles till September, actually last Thursday, and when we learned that we had been approved. So again, lots of high-fiving in the hallways. And as we've said, now the fun begins. We did get the approval across the finish line, but we also now have a lot of opportunity to work very, very hard. This next slide is our website. This is part of Coffee Regional Medical Center's website. It's the letter to potential applicants that Dr. Denton has authored, talking about our program, talking about the mission of our program, and how it fits with the needs of our community. So in addition to us offering to medical students who wish to be internal medicine physicians a great opportunity to train in a very good hospital with multi-service line opportunities, we can also promise them the opportunity to make a difference. We know that our residents are absolutely going to be game changers for our community, the health outcomes, and the needs of our patients when it comes to chronic disease management. So I couldn't be more excited to talk with you about the program. I can talk all day long about it, but I hope that you will give some consideration to the pretty significant financial needs that new residency programs have. I've got a sheet about residency programs that I'm going to leave with all of you. Mathematica produced that, and it has a lot of the principles that we considered when we were deciding to do the program. So thank you, Dr. Sumner. Thank you, Dr. Denton. We're very proud and happy to be here representing Coffee Regional. Thank you.
Thank you so much. We've got, who do we have next? Dr. Hannah? Is that correct?
All right. Well, thank you for having me here and the opportunity to speak in front of you. I think I want to be mindful of times. Maybe we're a little bit behind schedule, so I'll try and be as brief as possible. And to be honest, Dr. Denton and Vicki have covered this topic exceptionally well. So I hope maybe I can dovetail on that and just provide you some additional thoughts on things that I've seen that have been especially beneficial in recruiting physicians, particularly internal medicine physicians, to rural and underserved communities, and maybe some challenge in future directions and things that we could be doing to enhance that even further. As a little bit of background, I've been in graduate medical education, less so undergraduate medical education, for over 25 years. The first 20 of that was in the United States Air Force, and I will say this discussion is not atypical to me. We could force people to train for 4 years in the Air Force, but we had the same challenges in keeping them there and wanting them to stay in the military and complete a 20-year career. So some of the things I'm mentioning today are also things that we had to employ in the Air Force as well. The scope of the problem has been well stated, but I'll also point out that this is a problem that is likely to get worse through the next decade. And the reasons for that are those physicians that we are talking about that are in the rural communities are nearing retirement age. And so we are about to experience about a 25% loss in our physician workforce in our rural communities. And this physician workforce is really a healthcare workforce issue, but it's not just in rural communities, it's everywhere in the United States. And while medical schools have increased their admissions by about 30% to help address this workforce, the actual number of rural applicants to medical schools is decreasing. And Dr. Sumner, I heard her speaking this morning, and validates the stats that I have. But currently in the United States medical schools, our rural matriculants to medical school represent less than 5% of all medical school students. Right, so this is a real challenge that it's actually likely to get worse in the short term before it gets better. Dr. Sumner touched on the importance of reaching out to our rural applicants early and often, starting as early as high school. And so having very rigorous mentorship opportunities, particularly with physicians, to encourage those individuals to pursue careers in healthcare is vital to encouraging them to move forward. Many of these communities lack the resources and don't have advanced STEM programs in high schools. And so just providing that spark, as little as it might be, to encourage them to pursue careers in healthcare is going to be encouraging for them. And also volunteer opportunities at hospitals and the like, so they can see what a career in medicine might look like. I had the unique opportunity to attend the AAMC regional conference in Miami in January of this year. And I was struck with one of the presentations, and I immediately sent it to Dean Sumner, but it's called the Medical Education Development Program, and this was pioneered by the University of North Carolina. But this takes underprivileged and individuals have demonstrated educational promise in college, but have traditionally lacked the resources in order to pursue a career in medicine, and takes 60 of those in the state of North Carolina and puts it through a very rigorous 9-week curriculum during the summer months. And it's not just, those 9 weeks really simulate the first semester of medical school, but it's not just the medical school curriculum that's important, it's the support they provide them to get through that curriculum. So there's coaching, there's mentoring, test-taking strategies, there's career counseling, there's all those things to wrap our arms around these individuals that otherwise may not be successful with this rigorous curriculum. And for those who graduate this 9-week program leading up to their senior year of college and enter medical school, they have a 68% retention rate for those individuals to graduate medical school and go back into those rural and underserved communities. So this is an example of an immensely successful program. One additional resource they provide is they provide a stipend, $3,000. $2,000 provided after, I think, the first month, and then the last $1,000 of that provided when they finish the program. And they provide housing, so they put them up at UNC. So this is a type of program that I think we could easily do with our medical schools in Georgia to encourage our rural and underserved applicants to go to medical school. Some of the partnerships that I've seen with undergraduate medical education that have been immensely beneficial in keeping our physicians in Georgia and in rural communities. Mercer understands this completely. The best success is getting rural applicants that know small communities and have not been in urban environments, because they are the most likely student to return to their small community. With the work of Dr. McCann and the admissions committee, Mercer's matriculation is close to 50%, maybe even north of 50% with entering class and rural applicants, and that is making an immense difference. But we need to move beyond Mercer and encourage our other medical schools in Georgia to do the same. We have an accelerated track program that at my facility at HCA Healthcare Memorial University Healthcare Center in Savannah takes students after their first year of medical school, and if they have an interest in primary care, right now internal medicine, family medicine, pediatrics, and I really want to get one going in OB as well. But after that first year, if they meet certain quality metrics, their next 3 years, they complete the medical school curriculum in 3 years and are already pre-matched in a residency program. So they get to forego that entire challenge of matching into a residency program. And they also have at least 2 years of their medical school tuition is forgiven. And this has been amazing in getting our students into rural communities. I don't have the stats, but I know that the vast majority of them end up serving in those communities that they've committed to. The Nathan Deal Scholarship Program is another opportunity. It's also been extremely successful. But I will say that one other consideration to think about would be to provide partial tuition reimbursement plans, where we can pay for a portion of a student's medical school tuition to encourage them to participate and to serve in rural and underserved communities when they finish their residency. That is not necessarily linked to primary care, because as you've seen, we also need specialists in these communities. And so it is a little bit more flexible. I will say the disadvantage of the Nathan Deal Scholarship and the ACT program is you have to decide pretty early on in your medical school career that you are committed to primary care, number one, and serving in a rural community. And that can be very challenging for people that are uncertain, or the pressures that Dr. Denton just mentioned, where the financial incentives are so heavily skewed towards specialty medicine that they're unwilling to make that commitment at that time. So if we had a partial tuition reimbursement where they could pay back those loans either interest-free or a very low interest rate, that would encourage some of those, after they've pursued specialty training, to come back to those rural communities. And then lastly, let me just talk about GME opportunities. I consider the triple threat to be a Georgia resident who attends a Georgia medical school that goes to a Georgia residency. We can retain somewhere of 50 to 60% of those individuals. But what more could we do if we had a Georgia resident, Georgia medical school, and a Georgia rural residency program? And I think that is ultimately where we need to go. So right now at HCA Healthcare, we have a rural residency program in Waycross. This is Memorial Satilla. This is a program that's been in existence since 1998. I've had 81 graduates since that time. And we retain about 50% in rural Georgia. We retain about 80% in Georgia. In our last graduating class, we retained 100% of those graduates in Georgia. So this is the type of success that we're talking about. We recently launched a family medicine with obstetrics to try and address the maternal mortality rate in the state of Georgia. And so we're training 1 or 2 family medicine residents with specialty training in obstetrics to go back in our rural communities to provide that necessary skill. And we're continuing to explore opportunities to develop an internal medicine residency program in Dublin, Georgia, and right now committing to additional educational tracks in both Vidalia and Dublin as well. Currently, we also are relying increasingly on our rural communities for vital skills we can't even get in Savannah. So we are sending our OB residents to Statesboro to get basic laparoscopic training that we can't do as much in Savannah. And we're sending our surgeons to Dublin, Georgia to get general surgery because they get better opportunities in that community than they do in Savannah. And so lastly, I think ultimately the most successful programs identify residents of rural communities that have demonstrated educational opportunity and the desire to pursue healthcare. We wrap our arms around those, and ideally what I would like to see is early in college that we guarantee these individuals admission to our medical schools as early as the sophomore year, assuming they meet certain standardized criteria. But we offer them and guarantee them admission. And then when they're in medical school, we link them immediately with rural training programs like internal medicine programs in Coffee County. And in doing so, I think we can dramatically change the tide in our rural and underserved communities. So thank you very much.
So we have Glenda, there you are.
I'm Glenda Grant. I'm here with my colleague, Harvey Lee Moody. We work at the Georgia Rural Health Innovation Center here at the Mercer University School of Medicine. We want to very quickly demonstrate a tool for you that we think could be very helpful in your work. Rural data is hard, particularly knowing where there's access. And so traditionally, we've had licensing data, which tells the story of where the physician is, but it is only a snapshot in time. And so it doesn't tell the story of access. So you know where they were when they got that licensing data, but you don't know if they're retired. You don't know if they're in academic medicine. You don't know if they're the medical director of a long-term nursing facility. It doesn't paint a picture of who is actually in that rural community living and working and taking care of patients. And so we began thinking about this problem. How can we solve that? And being the Innovation Center, we put our heads together, and Dr. Sumner said to us, we need to ask the people who live and work in those communities. They're the ones who know. Like when they used to call in the football scores for football Friday night, and you got the information from them because they were there at the game. That's the best information. So we put our heads together, we got with our friends down at Mercer Engineering and Research Center, and we began a platform where people from our rural communities could go in, they could enter data. We have a community health reporter for all of our 120 counties. They can go in and put information about what practices are there, what physicians are in that practice, if there's an advanced practice provider that's there, so that we could have a live look at who's actually seeing patients in a rural community. And Harvey is going to demonstrate this. We do have a one-pager in your folder there so that when you get home, you can look in that. But just remember, we are the Georgia Rural Health Innovation Center. So if you're from a non-rural community, you don't have a reporter. So your information will not be in there. Only our 120 rural communities.
Good morning, everyone. My name is Harvey Lee Moody. The handout in your folder shows exactly what I'm going to show you today. And so if you start off on our website, georgiaruralhealth.org, and you click on the menu and then go to Georgia Health Data Hub and click on our Health Access Locator, this website shows where care is in our rural communities. Our community health reporters report on a different site, and their data uploads directly into this site here. And so in this top section, you can refine your search. So for the first example, we're going to look at Elbert County. We have a husband and wife duo that they're both community health reporters. One is doing for Elbert, one is in another county, kind of slipping my mind right now. But if we look at Elbert County, we see here that we have 6 practices in this county, and a community member in Elbert County can see where they can get care in this community. And so we can scroll through the different locations where care is provided. And for instance, at the Medical Center of Elberton, which is one of our partners, you can see who works in that office, their hours, their phone number, and what days they are open, as well as the other locations in that county. And then we'll also look at Washington County. And so same thing, we're showing 17 practices in Washington County, and you can scroll through and look at the different locations and who works at those locations. And on the bottom of your handout is our contact information. You can always reach out to us. We're able to pull reports and make maps to show what's available in certain counties. Thank you.
Thank you so much. I believe what we're going to do right now is take just a 5-minute break. I'm going to put you all on a timer for 5 minutes, grab some coffee. We've got one more presenter before lunch, just trying to stay on track. If you guys missed the coffee, it's there. Thank you. Timer is starting. Oh, I'm sorry. You know what? Hold on. Yes. Yeah. I know. Hold off on the coffee just one more minute. I'm so sorry. But I do want to leave room for just 3 questions. You all at the table, if you have any questions, we want to leave that open for you. And again, because of time, we are going to limit it to 3. Does anybody have any questions?
Expect to be, because I know Vicki and Laura quite well, and that would be as I expected, and I congratulate you on what you guys have done. I don't know you, Dr. Hannah, but thank you. But I really enjoyed that. One of the things that I believe we could offer in helping them is comes by aegis of the physician, rural physician loan repayment program. The repayment, I don't know the exact name of it, but the amount of money that we give new practitioners in rural areas, what's it called? Y'all don't know either. Yeah. Well, I was very interested in that from a surgical perspective, so I got my legislator to call that particular office in Atlanta to get the data, and I was told it was online. Well, that pretty much cancels me out. But my medical students looked it up for me, and it's not online. And I wanted to know how many people have received that loan repayment, where they're practicing today, what specialties they're in, et cetera, see if the program's working. And I would highly suggest to my legislative friends that they ask for an audit of that program. Is it working? Is there something we could do to make it better? You know, do we need to shut it down and make a new program? Well, one thing I was thinking, pursuant to Dr. Denton's discussion about the tremendous amount of loans that preclude people into going into internal medicine, much less going into it in Douglas on a new program. Supposing that loan repayment got earmarked while you were in residency, I think that would be an incredible incentive to go to Coffee Regional for some of these people that might overlook a new program. But I think first and foremost, I would really like to see an audit of that program. How's it working? Who got the money? Are they still there? You know, has that done what it's supposed to do? Or could it be enhanced, or could it be changed to meet some great program, right? It's a great program. The idea of it's a great program. I, for one, just don't know where to find the data on it. And if I don't know if you guys would be any more successful than I was. John Burns is who told them to look it up for me. And that didn't work. But I suggest it needs to be audited.
One thing related to that, and thank you for bringing that up. One thing we did in the military that has similar value here is that we would pay people in medical school a stipend in order to encourage them to join the military. And in the same way, many of our residents, one thing we didn't describe is that when you're a resident in internal medicine, you're not making $250,000. You're making about $60,000 a year for 3 years. And that's a really critical time in their professional development. They're having to start to pay back their student loans. And the amount of money they're earning is, it is significant, but they struggle to make ends meet with the cost of living, housing, particularly in some of our urban areas where they live, and then also having to repay those loans. So initial opportunity would be to offer them a additional payment while they're in residency to bolster their income during that vulnerable period of training, to encourage them to then go to a rural or underserved area after they finish residency.
And I agree with that too. I am thinking that to get a resident that has an opportunity to go to an urban residency versus a new community program like Douglas, you have to pay them more. And I think that's where I was mentioning a stipend of some type to pay the actual resident. We have a lot of residents in Savannah, or we have in the past, that when they choose a small community, that community pays them a stipend. And I know that Coffee County did it when I was a resident. I worked with multiple residents that are still in Coffee County, but they got a stipend. I think we have to increase the pay for people that go to the country to learn medicine.
I would say start with something you already have, right? Just tweak it a little bit. It's hard to ask our very, very good fiduciary managers in the state for money. But if you can change something, and I appreciate y'all's conscientious stewardship of our taxpayers' money. But, if you already got something there, and you might could just modify it a little bit, that would be a win-win.
I think the stipends that have been mentioned are absolutely successful, even when we are bringing home medical students, interns, residents, fellows back to the community to practice. We oftentimes put on some kind of stipend during their fellowship. Lots of them are married and have kids, and they simply can't support their family on the fellowship salaries. The other thing I would encourage is some of the $2.2 million that I mentioned earlier, there's a prohibition against us using those dollars for salaries. So we're not allowed to use them for resident salaries. Those are exempt. The state budget line item allocations that we've received, we can use towards salaries, but some of the other dollars we cannot. So you're bringing up a really good point. I think it's difficult to really look at the economics of it when you've got a family.
And I really want this program in Douglas to be successful, because I do believe that if you get young residents to communities, they will stay there once they realize how the relationships in small communities are just so different than bigger places. But when you go online and look at other residency programs in the country, many residencies give extra stipends. They call it a cost of living stipend. And so a good example would be Duke. Duke has a very robust internal medicine program. They pay their residents starting about $68,000 to $71,000 a year, which is more than what we're paying in South Georgia across the board. But they also give them a cost of living food and living stipend as well, in addition to that. So that gives them extra money for the daycare, for the spouse to stay home if they have small children, those kinds of things. And that's a really, really a good and a progressive idea.
Chairman Parrish.
Dr. Odom brings up a good question. I think some of this information, Doctor, should be through the Physicians Workforce Board, probably.
That's right.
And we're doing better than we have been, but we've got a lot of opportunities to improve the information and then get that information back. I remember years ago, Dr. Summer told me in Johnson County they had like 10 doctors up there. And, well, there may have been 10 once upon a time, but they're either deceased or retired or whatever, and there was one practicing, and that was it. So that was all there was there. But that information and data needs to be current and live, so to speak. And y'all have touched on this, and I'd like to sort of get your ideas. If you look at what the residents are paid while they're doing in their residency training, and we talk like $50,000 to $60,000 or something like that, how much money would it take to get their attention? In other words, if you decide, okay, we're going to offer a cost of living stipend or something like this, how much would it take to do that? And I know some of our neighboring states, Florida and some others, are doing that, and it's making a difference. But it gets back to what we talked about earlier. If you take a Georgia resident and you train them in Georgia, and they do their education in Georgia, do their training in Georgia, chances of staying are very high. So we've not done everything that we need to do to make that happen. So give us your thoughts on what we can do and how much does it take to make that happen, please.
I don't think it would take a lot. I think just being able to know that you can manage your bills, and having the difference between really struggling to just being able to feel comfortable in your finances would be what it would take. My military example, I think, depending on your commitment, whether it was a 3-year or 4-year commitment, was on the order of $20,000 or $25,000 additional per year.
I think 25 or 30,000 would absolutely be very meaningful. I also think that the availability of affordable housing is a key component. One of the things that we're struggling with a little bit is exactly where these residents are going to live. We've made a little bit of inroad there, but again, I agree with Dr. Hanna. I don't think it's doubling the 62,000 or 65,000, but I think 25 or 30 would be terrific.
Representative Osteen.
Thank you so much for this very informative presentation. Vicki Lewis came and transformed I'm from Coffee County, for those of you who don't know, or forgot since I said that. She transformed our hospital, and she's been phenomenal. She has vision, she's very cautious, she's very grounded, and I'm so thankful that she came to Coffee. A year or two ago, I heard our mayor say something about workforce development. And whenever industries are coming in, they're looking at 4 major things. They're looking at your roads, what kind of transportation to get products in and out, education system, your workforce, what kind of workforce do you have? Are they healthy, unhealthy? You know, how many people do you have that's going to work? And then your healthcare system. And so I have noticed, I've been in Coffee County for 31 years, and I have noticed in the last 10 years or so a tremendous growth in our community, but just like she just said, the housing is an issue. So in talking about the stipend, is there a way that we could, if they take the stipend through the hospital, that we can kind of hook them into staying with us in that one community for the, $20,000 or $30,000 a year? I mean, if the state does that and funnels it through these teaching hospitals, is that a way that we can keep them in these rural communities?
I think it absolutely is. I'll just use an example. Again, our Bring It Home strategy included a young man, Josh Vickers, you probably know him, who is fellowship trained in orthopedics, grew up in our community, went 2 years to South Georgia State College, went off to Georgia, then went to medical school and orthopedic residency and did a fellowship up at Emory. While he was at Emory, we put on a stipend for him. He and his wife were living, obviously, in Atlanta. There was a payback on that stipend. So there are lots of federal guidelines about the compliance component of those stipends, which we follow very stringently. But it is a great stay opportunity because the physicians have to practice, for a number of years following the stipend being put on and stay in the community to pay that off. So they don't pay it back in cash, they pay it back by helping you meet your mission. We've also done the same thing with school loans. We try to help them, if we can, pay down their school loans. Oftentimes that's a barrier to them purchasing a home. And so we try to do that. And then we put a practice, length on that loan as the payback rather than cash. So those are very, very effective. The difficulty is we have to have the cash to be able to do that because that's cash. So we're really careful in that. But that's a great point.
I was thinking that we would pay residents that went to a rural community more money than someone that went to an urban community. And the reason I think that is I don't have this personal experience, and maybe my colleagues do, but I know that a hospitalist in Manhattan makes a lot less money than a hospitalist in a more rural area, mainly because more people want to be there. It's a big urban center. People want to be in Manhattan. They make less money because they have many more applicants. So if you make a rural community more money for that person, but you don't incentivize the persons going to the urban residency programs, I think that will be successful in the end. Because there are people that will look at two residencies equally, but go for the one that has the larger salary, the stipend, just because they need the money. Don't you agree?
Go ahead, Representative Rick.
Thank you all very much for your presentation today. It's very informative. But my one question, Dr. Hannah, is you said something about the guarantee for a student to get into. What is the obstacle there, and why is that not able to be done?
Medical school has traditionally been very competitive, and I think Dean Sumner spoke to this earlier. We typically have very rigorous academic standards, but it's been sort of immutable over time. You have to meet these specific requirements, and if you don't, you can't even get a foot in the door. Mercer, to their credit, has really started to change this paradigm and looking at the rural applicants and developing metrics outside of test scores and GPA and other factors that traditionally have been looked at, and trying to understand if we have a rural applicant that lacked the resources in high school and didn't have vigorous STEM programs, what are those attributes of a rural applicant that still makes them likely to be successful in medical school? And Dr. McCann can speak to this at length, but they have great data that shows that our rural applicants, even if they underperform compared to traditional applicants in college, they're equally successful graduating medical school. So to your point, I think it's just continuing to understand what are the attributes of a student beyond GPA that's likely to make them successful in medical school, and identifying them as early as possible, and then guaranteeing their admission into medical school.
Dr. McCann can back me up if you're still here. You're still here. If you look at the traditional metrics for medical school, our lower 20% are equal to our upper 20%, and there's a span. And those are rural kids who come out of public schools who don't have the opportunity that a kid in Buckhead has. I mean, they don't have the museums and things. They have work ethic, because most of them work to get here. So it works. Mercer has, and other schools do too, early consideration program where you interview freshmen in college, and they're interviewed by the faculty at the medical school, and they complete a rigorous curriculum, and they do not have to interview again. They have to take the MedCat to come in, but we know they're mission compliant, and we accept them at that point, which is a good way. They've just started with working with Dr. McCann a 3-year track So you'll come into a pre-med track. We help check the curriculum, make sure it was rigorous enough. They come to medical school in their 4th year of college, but finish the first year. If they finish that first year successfully, then they get their degree from Mercer. Now, that is not new. I have an older brother who just retired from medicine. He did it at Emory years ago and forgot to go back and get his BS. They gave it to him later, but it's not something new. But it kind of, we went away from it, and I think it'll work. Because part of that time in college is for, new horizons, a few parties on the side, a few extra courses. I mean, sometimes you don't need that 4 years. Some people do. But we set very rigorous criteria. So we're going to see how that works, but I think it'll be successful.
So I want to thank everybody. I apologize. I was very excited about the coffee. But thank you so much, Dr. Sumner, for this panel. The information that you've provided has really been helpful, the recommendations. So thank you so much for your time. And it's coffee time. So we have Matt Lyon, the director of MCG, Center of Telehealth Professor from Augusta University. Thank you so much.
We're good, right? Okay. Hey, thank y'all for having me to come and talk to you this morning, just to tell you a little bit about our digital care network. I'm going to try something a little unique today, and so I have a little bit of apprehension that things are going to work out right. So I made some notes about what I'm going to say in case I get very confused because I get nervous up here and I talk too fast. But I really appreciate this. I mean, I'm going to try and highlight 3 critical areas that's really important for access for our rural Georgia citizens. One of them is that digital care can extend comprehensive care into our underserved rural areas. Another one is how innovative digital care models can improve quality of care in rural Georgia and also reduce the strain on our urban hospitals. And then finally, why it's so important to train our future physicians and workforce in digital health, because that's the way of the future of how to create access in rural Georgia. So I have brought my my tech support, so he's going to help me a little bit because this is a little bit high wire, so hopefully everything runs great. I just wanted to tell you a little bit. Everybody knows the rural healthcare, how it is and the disparity, so I'm not going to cover that at all. But what I would like to say is that rural hospitals are a key vital resource in rural communities. Those rural hospitals provide an access point for when you have a very good primary care internal medicine practice in rural Georgia. When a patient gets sick and they need acute care services, that local rural hospital is really essential and unbelievably important for that patient's healthcare journey. Making patients travel outside of rural counties to come to cities and urban areas to get care leads to fragmented care and also leads to poor quality of care. What faces rural hospitals, though, is that transfer. It has been made very easy for hospitals to transfer to urban cities. It is really easy on us doctors to bring patients to us so that we see them and pull them out of their rural county hospitals. But what that does is it leads to a very negative cycle where rural hospitals don't have as many inpatients, they can't bill and collect, so they have less revenue coming in. And when they have less revenue, they have less services. They can't afford to pay for people, equipment, machines, those kind of things. And then worse yet, the workforce loses skills because they take care of lower and lower acuity patients over time. And what that means is it builds a community perception that that local rural hospital is not where you can get care. You're going to get transferred. It's a Band-Aid station. And all of that just leads to a negative cycle. You can kind of see it on the side here, some of the things it leads to, but it leads to delays in both emergency acute management of disease. It leads to delays in management of chronic disease, but it leads mainly to a loss of coordinated care. And so it's very fragmented in our rural system. And if you start thinking about why is it different in urban and rural, why is the mortality different? A lot of it has to do with fragmented care. And even though we have very good primary care doctors, internal medicine doctors, and practices in rural Georgia, if you ship a patient to a city, then you lose track of that patient. Sometimes they're gobbled up by other healthcare systems. Sometimes that what happens is that they just don't get the records back, and it leads to redundant testing, it leads to redundant therapies, and we're going to look at that in just a little bit more. But what I want to say is that leads to more disease, more poorly controlled disease, and also leads to higher healthcare costs, none of which we want, and higher morbidity and mortality. So with all of that said, just let me tell you a little bit about the Digital Care Network. The Digital Care Network has been around for a long time. It's changed names over time, but this was started in Augusta at the Medical College of Georgia. It is a digital program to extend specialty care out into rural Georgia. Currently, it's in 42 rural county hospitals and FQHCs and DCH centers and private practices across rural Georgia. What that does is it allows for specialists to tie in either digitally through like a digital stethoscope or digital devices, or just seeing patients, you know, across the TV like we're doing here, so that those patients have access to those specialty services without having to leave their county. What I want to focus in on with that program is our rural hospitals that participate in this program. Currently, we have 15 rural hospitals participating since about 2019. We'll be at 20 hospitals towards the end of the year. We have 5 onboarding now. What we provide is 24/7 access, 365, to specialty physicians that are dedicated to providing that care in rural Georgia. What this means is that if you show up in a rural emergency department that's connected to this system, you have a fear of disease, you know, the doctor taking care of you has a fear of disease, they can get a specialist to see that patient live 24/7, 2 a.m. in the morning, adult, pediatric, emergency medicine, critical care, surgeons, OB, they're all tied into this system. And then we're able to bring in even more specialists in what we call an e-consult process, which means it's not available 24 hours a day. But if you admit somebody to the hospital and you need an infectious disease doctor, we're able to bring that in also so that that patient in a rural hospital has access to that specialist and that specialty care. This is about patient care. This is about delivering high-quality care in the county and the hospital where the patient chooses to live and get care. And so it's extending that, but it's also about helping keep rural patients in rural hospitals because, again, we've got to reverse that cycle. If we can keep more patients in rural hospitals with high-quality health care, there's more for the hospital to bill and collect and revenue coming in. On the flip side, then they can invest in their people, processes, and equipment so that they have the ability to take care of even sicker patients over time. It's really a win-win-win. The rural patients are winning, the rural hospitals are winning, everybody's winning in this. It's lower cost of care, less transfers. It's better for the whole, all of our rural citizens. There's less health care disparities, so we're able to give the same quality care that we would in an urban environment where I can reach and touch a patient to the patient that may be several hours away in a rural hospital. So just to give you some stats, this is just the last few years. Again, we have 15 hospitals participating in this network. We have 5 onboarding, so we'll be 20 hospitals, somewhere around 50, 55, critical access and rural PPS hospitals across rural Georgia. So pretty good percentage. We've seen over 6,000 patients. That's about 14,000 encounters, meaning that when we see a patient in a rural hospital and they get admitted, we continue to follow them along. So we follow them during that journey so that we can help identify, something not going according to plan and make sure that we're taking care of that early and not having to transfer a patient to get something done. Sometimes you still have to transfer a patient, but our goal is to get that less than 25% of the people we see. Right now we're running about 27. If we didn't have this program, over 90% of the patients we see would have been transferred. So that's still a remarkable reduction. One example is Candler County Hospital, which is Metter, Georgia. When the governor did the task force and looked at, our rural hospitals and the ones that are most likely to close, Metter, Candler County Hospital is number 2 on the list of risk of closure. They had an average daily census in their 25-bed critical access hospital of 3. So every day they had an average of 3 patients. Their skills were degrading, they were losing money, their critical access, so they get other support, but they were really at risk of closure. We came in, along with some other things, reversed that cycle. Today they are 25 and they're full. They're full all the time. They have a swing bed program, as some of y'all may know, so they have actually people waiting to get into their hospital for rehab. Case mix index is kind of a scoring system to tell you how complex your disease is that you're managing there. When we started, it was as low as you can get. 1 is as low as you can get. It's a ratio. They're up to 1.5. So that's a massive increase. It doesn't sound like a big number change, but that's a massive increase. And their cash on hand has gone from 2 days to over 6 months. So that's what we're talking about. Now, relating this back to our primary care physicians that are in rural Georgia. If you don't have a hub like that that can be your service where your patients can, as you're managing their chronic disease, as they have issues that come up and they need to go to a hospital, if you can't manage that there in your county, that primary care physician is going to lose control of that patient. The urban doctors are not going to ask the primary care doctor, hey, I saw you were treating this way. Let's help you do that. It's not going to happen. So we need to keep patients in rural Georgia so that they have that continuity in that primary care. One of the barriers, though, is that people, I hear this all the time, telemedicine, that's me trading seeing that patient in person where I can touch them for a patient on the TV screen. That's 1 for 1. How's that making me any better? Kind of like FaceTime. You can go see your mom on FaceTime, or you can go to her house and get a hug. Most people would like to get a hug. The thing of it is that when you get past that initial thought that it's a 1 for 1 replacement, you can bring in digital technology that actually help you take care of patients better in their environment. So instead of tailoring something for a patient to what life would be like in a city. We can tailor it to what life is like on a farm. With digital technology, we're able to be there in their environment. Another way of thinking this is you take care of a patient inpatient. Some of y'all have been in the hospital or have had relatives in a hospital, and doctors and nurses and the whole team work really hard to get their blood sugar under control, and it's awesome. And then they go home and it's out of whack. Why? Because their food changed. Because maybe they didn't understand their medicine so well. So being able to be with a patient where they are allows us to adjust that. Not yet, Matthew. So one thing that we're going to do here, I'm going to take you on a journey. They've been waiting for a little bit. We're running a little bit behind, but we have arranged for you to participate in that kind of journey so you can understand what I'm trying to tell you. So this is Dodge County Hospital. You guys can hear us okay?
We can.
All right, perfect. So what we're doing here is, this is Daryl and this is Nurse Kara. And so Daryl is a patient that has had very irregular glucose. This is, I'm looking over here, and we can see his Dexcom. We can see how he's way out of control. He's having very high blood sugars and very low blood sugars. Not really sure why, because I'm not in his home when he's doing this. And this is his blood pressure log that we've been measuring on him, and you can see that his blood pressure is up and down, but it's mostly up. It's not in a good way. Daryl, recently, what was it, Daryl, about 2 weeks ago you had surgery on your foot? So he has diabetes, his sugar's out of control. It led to complications in his leg. He had to lose part of his foot, as you can see. So he came to Dodge County ER today because he was having a lot more pain. He was really worried that he was having an infection. So we evaluated with Nurse Kara. Nurse Kara, can you tell us just a little bit about what the foot looks like?
Yeah, it's pretty red. It's got some pus, it's a little warm to touch. It looks like it might be a little infected.
Yeah, and Daryl, we talked about this a little bit ago, but, you know, with your sugar being high, it's really hard to fight off infections. And then, you know, with your blood supply going down to your foot a little compromised, a little challenging to get that to heal up, even though it's been a couple of weeks. I think we're going to need to put you in the hospital. Let's keep you overnight. Let's give you some IV antibiotics. I think we need to get your sugar more under control. How's that sound?
I don't do well in hospitals, and I just got out of the hospital like 2 weeks ago. I mean, could this be done at home? I mean, I have an elderly mother that I have to take care of, so it's hard for me to get somebody to watch her while I have to go to the hospital. So if there's any way we could do this at home, it would be helpful for me.
Well, I think we'll explore that in just a little bit. We'll think about how we can do that. But while we got you there, you know, I've been pestering you because you smoke, and so we worry about your big blood vessel in your abdomen. You know, it can dilate because of disease. It's called an aortic aneurysm. Do you mind if we go screen you real quick since we got Nurse Kara there?
Sure, that'd be fine.
All right, Nurse Kara, while you get him set up, just to kind of fill you in what's going on here is that we've got all of our technology is tying in, so we're able to really see a comprehensive picture of what's going on with him in his life and why he's having an exacerbation of his diabetes that's causing him not only to lose his foot, but also because why he's not healing well and why he's having an infection now. So, you know, if we had his sugar under better control, we would more than likely be able to keep him out of the hospital a lot more. So here, Kara is doing what most of us, you know, men don't like to do, get screened for disease. So while we got him trapped, and he knows all of y'all are watching him, we're going to make sure he gets his screening. Okay, go ahead, Kara. All right, so Kara's just going to screen his abdomen. I'm going to move away from the mic for a second. It's a little dark in here, but this is his aorta, and that black circle right above my finger is his spine, and the black circle is his aorta. And what we're looking for is a dilation of his aorta. So Kara, slide down towards his feet a little bit. All right, keep on coming, yes. And now it's breaking into his two main vessels that go into his legs, and they've already been checked when he was admitted last time. And come up towards his head for me. And we're just looking at that. It's not dilated. So he does not have an aortic aneurysm, though he continues to smoke. So, Daryl, we're going to work on your admission. Everything looks good from there, but I do think you need some IV antibiotics. So while we keep working on this, do you mind if Nurse Kara gets to working on that kind of stuff?
That'll be fine.
All right. Well, the other thing that I want to switch bases for you just for a second, since you've seen how technology can work in a rural hospital, is to talk about innovative, digitally enabled care models that we can do for patients in rural Georgia. What we do in urban cities, and not everybody has this yet, but this is pretty common around the United States, is being able to use digital technology not only to keep people out of the brick and mortar facility, but also to monitor them after that acute care admission so that we keep them from being readmitted, very much like Daryl here. And so we have names for them. You can kind of see what I named them, but one I want to point out is called Hospital at Home. That is a CMS waiver program where you can take care of a patient in their home as if they're in brick and mortar. Clearly, they're going to be a lower complex patient, but they meet admission criteria, and they should be in a brick and mortar hospital, but we're able to take care of them in their home with some caveats through digital technology so that they don't have to be in the brick and mortar. That takes that patient out of the brick and mortar so there's more rooms, there's less ED holds, and people waiting to get in a bed. It's also lower cost of care. So this is a little complicated, so I made a little bit different slide, and what I want to point out is that you can replace taking care of people in a brick and mortar hospital. You can do it in their home. You can do it with digital technology and a lot of caveats. That's what all those lists are for. We have to do things for the patient in their home, but we're able to do that remotely with people coming in and out of their house. If it's something that should be in the brick and mortar hospital, like you got admitted for pneumonia and you need IV antibiotics, or in case of Daryl, you have a cellulitis in your foot, that's called Hospital at Home. That's the CMS waiver program. The hospitals are paid just like you're taking care of them in a brick and mortar hospital. Once you get discharged, we call it recovery care at home. In other words, we're watching you for 30 days to make sure that your care plan is going well and that you don't get readmitted. This then can turn into more than 30 days, and that would be more chronic care at home. All of these, what makes them all work is that digital technologies in the home watching patients. Let's talk about hospital at home. It may be a new concept. We're the first hospital in Georgia to have this program. Others are following behind, like Emory and Atrium up in Rome. But we're the first in Georgia to have this program. It has a lot of benefits. Why does it matter for rural Georgia? Because these benefits of this program can't be realized by patients in rural Georgia right now. So more health benefits, less complications during admission, so less delirium, less hospital-acquired infections, but less need for rehab because you keep a patient ambulatory if you keep them more in their house while you give them the IV antibiotics and those things. You have more comfort for the patient. Patients like to be around their family and their social support instead of being in a hospital. I like to be around their own TV, by the way, so they can watch their own football games. You also empower them. You get them more involved in their health care. They understand why they need to get out of the chair. They also understand why they need to stop smoking because you're able to do it in their environment. We're actually going to go see Daryl in his house in a second. So just remember, if I didn't catch you already, Daryl's a fake patient. But Daryl, we're going to go see him in his home. He actually has everything that we talked about. He has trouble managing his sugar because when he gets home, he has to take care of his mother, and he doesn't eat right. He doesn't have access to great quality food like protein, and so his sugar is up and down. And so we're going to go visit him in his house. The key here is that we're able, when we're in his environment, we're able to tailor the treatment to him. If you bring a patient into our environment, we're tailoring his treatment to our environment, like his food. And so when he gets to his home, it doesn't work. This is very much akin to what, old-time medicine, if you want to think about it, house calls, right? Where the doctor went to a patient's house. Now we're able to do that, but we can do it digitally. And it has been proven in hospitals around the U.S. We're the only one in Georgia, but this is about 270 hospitals around the U.S. that do this. Decrease length of stay overall in that acute care period where it's so expensive. Decrease need for rehab, shorter recovery, back to the workforce, all of those things that we care about. Better patient satisfaction because we're able to do this in their environment. Okay, Matthew. So, this is a new model of care. Here we have Daryl. He's in his house now. Daryl, I see you back smoking again.
I get nervous, especially when I'm talking to the doctor. It's just a nervous habit.
Well, Daryl, you're killing me, man. You knew we were going to be in front of all these people, I mean.
I know, it's just a nervous habit. I'm sorry.
What I want to point out to you, and we're going to talk about primary care in just a second, is that Now, I'm one doctor, and I can look at multiple patients like this at a time. So this is the list of patients we're taking care of in their home. It's about 60 a day with one doctor. Think about how much different that is as if I was a hospitalist. Maybe I could take care of 10 or 15 patients in a hospital in a day. I can take care of 60 at a time. And I can do it continuously. And not only that, I can see how his blood sugar is going up and down with his home food. We can monitor his infection. Daryl, is your infection getting better in that 4 minutes since I've seen you last?
No, it's still the same.
Well, one thing that I'm worried about with
maybe worse.
one thing I'm worried about with Daryl is that I'm worried that he's not taking the right dose of insulin. So Daryl, will you go on and draw up your insulin? You know how much you're supposed to be taking. I'd like you to give that a shot. And then this is what I'm trying to get you to understand is because I'm in his home environment. These are real stories, by the way. Because I'm in his home environment, I can see his barriers to care. So Daryl, go on and draw that up for me. Daryl is doing something that we do very frequently. When we're digitally doing this with a patient, we're watching them do their own medicines and do their own health care. And so Daryl, that's about 15 units, right? Maybe show us the syringe when you get it all drawn up there. And then Nurse Kara's there in there. Hold it up for us in the camera. All right, perfect. All right, Miss Kara, I can see it. It doesn't look like 15 units. What is it?
Oh, it's about 21 units.
Yeah, that probably explains why we're having a little bit of trouble. And Daryl, why didn't you draw up 15 units?
Thought I did. It's what it looked like to me.
Yeah, you're having trouble seeing it?
I think so, yeah.
Yeah, I think.
No, about right there.
Yeah, that's what I'm worried about, Daryl, is I'm pretty sure, you know, with your sugar being high, that your vision's getting a little off, you know, and I think that that's why we're having so much trouble controlling your blood glucose. We're just kind of watching it down here. We're scrolling through some of your highs and lows. I think what we need to do is switch your insulin from that, you know, you drawing it from a syringe to what they call like a click pen. So when you click, it tells you, you can listen to it, and it helps you dial in the right number. I think that audible cue with your vision, I think that will help you get the right dose of insulin. Maybe we can get this under control. Well, I want to tell Daryl thank you for letting us see him in his house, and then we're going to move on. Does anybody have any questions about Daryl? All right, Matthew. So, yes, ma'am.
Just real quick, so you're going to need to rely on internet, his ability to have internet in the area.
Yes, ma'am. So that is one of the barriers. So one of the reasons why we started with rural hospitals, not only because of the benefits I told you, but rural hospitals generally have very good broadband access. And so they're the hub of the community and work out from there, but they also have connectivity. When we start moving out, even in Augusta, and we start moving into Richmond County, you start running into bandwidth issues. For our program, we give the patient a hotspot. It's part of the program. That helps in urban areas where you have cell phone towers you can reach. Now we're working on Starlink access for even further out in Georgia. So one of the key things here that I want to wrap up with, and I am at the end, is that none of this works without the comprehensive solution. So not a telemedicine company. I work for the state. I work for the Medical College of Georgia. MCG, the reason why that and Augusta University are so important is because it gives us the educational and research ability to come to our rural hospital. So it's really nice to be able to tell a rural practitioner, hey, keep that patient in that rural hospital, they'll be fine. But if they don't feel comfortable taking care of them, they don't feel like they have the skills or the connectivity to do that, we're able to beam in and help with the connectivity, but we also have to do the education. So we support our rural practitioners, the whole healthcare team, the nurses, the doctors, the respiratory therapists, the pharmacist, the social worker, the whole team. We support them with education so that they feel comfortable over time rebuilding those skills so that they make their hospital really a hub. This is just the last thing I was going to tell you. So, you know, we do that both monthly through digital education. We're already beaming into these hospitals. Why not just beam in and teach them something? So we teach them every month, and then we do hands-on courses for them twice a year. That's where they can learn to interact with us, play procedures, They get to do simulations kind of like we just did, where they get to practice their skills in a low-risk setting. And then we teach our medical students. So we're the only medical school in the U.S., I can say this proudly, that we teach all of our students. They're trained in telemedicine along with learning how to do hands-on normal physician practice, right? So as they're learning physical exam and how to talk to a patient in person, They're learning how to do that digitally too, so that when they graduate, we have a digitally enabled workforce that can take this to the next level, because I do believe that this is how we're going to solve some of the access issues in rural Georgia and equity issues in Georgia when it comes to healthcare disparities. And thank you.
Representative Hagan.
Thank you. Thank you for this presentation. This has been fascinating. I'm wondering if you have patients that are not so, maybe they're technology averse.
Yes.
I hope my dad's not watching, but I'm thinking about him. Have you found strategies or ways that you work around that? And will you talk about that for a minute?
It's so brilliant. The question is so awesome because it just made me think when you said your dad. I was thinking about the commercial where they're, screaming at, Aura or whatever, and it's really Alexa, and they're like, no, it won't answer and stuff. No, so the technology has to be at a barrier, very low barrier, so that they can participate. And so we provide all of the equipment when we're in a patient's home because it is a patient-first access. We do go into the patient's home with nurses and paramedics and things like that, but the equipment, if they have an emergency at 2 o'clock in the morning, they got to be able to get to us. So the equipment is designed specifically for that. It looks like an iPad, but it's an Android tablet. It has just a button, push contact. It's just big button, push, and then we can call into it and just start talking and seeing. So if you think about like privacy and stuff like that, you are giving up a little bit of privacy, but we're able to either call in without you helping us, or you can hit a quick button. They also wear monitors, so very much like, help, I'm falling, I can't get up. They have those kind of things, but also it's telling us if they fell. So it's got sensors in it, so if they fall, we know, it rings, we're right there. We can do blood pressure, glucose, pretty much anything you can imagine. We can tie into that, and they don't have to do anything. Now, if they're going to take their blood pressure, they have to put the cuff on and hit the button, but there's a big button that says blood pressure. So the barrier is very low.
Representative Osteen.
I'm fascinated by this too. So I was thinking like Representative Hagan was that, our parents are in their 80s. Yes. They don't have internet, live in Jeff Davis County out
I know Jeff Davis.
a long way out.
Yes, ma'am.
And I was just wondering, what is the name of the program that you use to, I guess it's preloaded onto the iPad. What is that?
Well, the company is called Bioformus, but there's multiple companies that do this. I mean, this is the technology of the future. As I said, for taking care of people in their home, hospital at home, the CMS waiver program, there's about 270 hospitals across the U.S. that do this, so there are companies that support that. They run into the same barriers, and I will say that both my mother-in-law, who is 82, and my mom, who's 78, have both been on this program. And, I was very nervous about that too, but they seem to figure it out, because it's laid out enough to where they can just call.
So you have a nurse or whoever's in that home shows them how to, and I guess they go ahead and, I guess it's Bluetoothed.
It is,
so
and they pair
everything's
it all up.
Bluetoothed, and then it loads up, and then you get all of that information.
I do.
And then what happens if he had been a real patient and he couldn't see, what was going on with his blood sugar? He didn't understand what was going on with his blood sugar. Who's monitoring what's going on with that blood sugar to alert you that we need a physician intervention?
So we have various ways of monitoring the sugar itself. You've seen like the Dexcom where you wear. We have that. We also have the finger stick. We have multiple ways of monitoring it. But that story I told you is actually real. It was, you have to see patients in this environment to learn how to do it, which is why I say we need to teach the next generation how to do this, because I'm just learning on the fly. Nobody told me how to do this. But literally what you just said was exactly what happened. We had a patient whose blood sugar, could not manage it. It was high, it was low, and low is dangerous, high is dangerous, could not manage it. And it turns out that we did pretty much what you saw there, but we did it without somebody in the home. And I said, let me see you draw it up. Well, I don't see you drawing it up. Can you pan the camera over? It was her 9-year-old daughter that was drawing up because she couldn't see. So she was asking her 9-year-old daughter to draw it, and it was random doses. And she was injecting her mom.
Right.
And that's just the way people live.
Right.
And so being in their environment, I'll give you another story. Being in their environment is that you see how other people live. You can't make judgment on how they live. That's how they live. but you can tailor the treatment to how they live and how they have to live. Give you an example, after the hurricane, there was a lot of damage to a lot of houses, and I went to admit a patient in their house, and I'm just sitting there talking to her, and we're going over things, and I'm like, can you tilt the camera up? Why am I looking at the sky? She's like, there's a big hole in my roof. And I said, oh gosh, am I going to be able to take care of you in your home when it's just out to the weather? And I was able to, she had it all prepared. They were coming to fix her roof the next day to put tarps on it and that kind of thing. But you start seeing how people live when you go into their environment.
And you see their food pantry and their freezers, and they're living
100%.
off of frozen pizzas, and the
100%.
diet's out of control.
Give you
They
another
think
one.
their diet's okay, but then you actually see.
Absolutely. One last quick one. So same thing, blood sugar going up and down. I pulled my trick. I'm like, let me say, no, she's giving the right dose of insulin. And so we get together as a multidisciplinary team. We start talking about the patient, like, what's going on? I'm like, clearly there's something wrong with the insulin. And the paramedic that goes in and out of the house goes, no. Oh, I said, I think they don't have any food. She goes, no, there's boxes of food lined up that, gets sent to her. We'll go open one of them. She opened it up. It was pasta and bread and nothing but carbs, no protein. Like, she had plenty of food, and we were shipping it to her. That's the bad part.
Okay, members and staff, lunch is provided outside behind me in the hall. Please feel free to eat here so that we can finish up this afternoon with the agenda. And we stand in recess until 1:15.
Thank y'all for letting me talk.
Thank you. Thank you so much. That was very informative.
Thank you.
We're going to go ahead and get started. We've got Jimmy Lewis, CEO of Hometown Health, and he's going to be speaking about AI. And we do have that presentation in your packet.
Okay, thank you for the opportunity to share some thoughts on AI as it relates to rural hospitals. A little bit about who I am. My name is Jimmy Lewis. I'm the CEO of Hometown Health. Hometown Health is a resource company who does, as we would say, whatever it takes legally, morally, and ethically to keep a rural hospital from closing. We've been in business 25 years. I've been there all 25. Prior to that, I worked in 6 Fortune 500 companies, and I'd only tell you that because it has meaning to the AI side of what we're about to do here. And those Fortune 500 companies, I had the opportunity to put together in one form or another 6 systems of sorts, process systems, and that has impact on what we're about to talk about with AI. But it afforded me the opportunity to see system work, got out of that, got into healthcare, and formed this particular organization, as I said, to do whatever it takes to keep rural hospitals open and going and whatever it's about. But before I get into that, I want to talk about one part something that is extremely important that we just heard today. You're listening to Dr. Lyon. I don't need to tell you this, but his story is an incredible story. Again, I worked in closures and all sorts of things associated with systems and that kind of stuff, and I can only tell you that as the basis for what we're about to talk about, he's done it. The only problem is he has to do it within the limitations of something called cash. And we've had many conversations about cash to the chairman here. I say again, when we start in this subject matter, in terms of what this committee can do is advocate for cash, and he's got the model. The model that he has had to develop, he's rounded up the cash. He's done a very good job of that, and it's incredible to see where that can go, particularly in rural Georgia and the need for what we've got going on. So I encourage you to do whatever you can to advocate for and to make sure that his program continues to go and grow and do all of the things that go with it. Now, having said that, we studied AI, generally speaking, we studied AI, we Hometown, we studied AI for the purpose of determining what impact is it having on rural Georgia. I could take an individual hospital or I could take several, but I want to share with you, generally speaking, what we think we're seeing happen. And I'll start off somewhat with the end of the story to back up to tell you what it's about. And I will tell you that from what we can tell, and I got into it a year and a half ago to study to see what the true impact on rural hospitals is and rural healthcare is. But I got to tell you, I've seen a lot of things, and you've seen a lot of things. We've seen a lot of things like the mimeograph machine and maybe the Gutenberg press or maybe the iPhone in 2008. And all of those things created disruptive behaviors of a sort. Of all of the things that I've ever seen in any form, I've never seen anything that has the capacity to be as disruptive, if left untended, as this whole subject matter of AI. And the reason that it is because you have great difficulty defining it and have great difficulty in putting your hands on it to touch it and weigh it. It doesn't weigh pounds. It doesn't weigh lengths. It is what it is, and we may have only just seen the beginning of it. Again, I've had the opportunity to do a fair amount of research for the last year and a half into this, and I will tell you that AI, as we see it and as we know it, will predominantly deal with the operational side of it, but then there's the clinical side that's extremely important. But we must understand that what can occur with AI is like something we have never ever seen or experienced in any form. It has the capacity to do things. I made a note that's kind of interesting. I was listening to a podcast the other day, and the podcast speaker was talking about we're now moving into the speed of thought. Think about it. We used to deal with the speed of light. That's nothing anymore. Now we deal with the speed of thought. And the speed of thought is what's driving the whole subject matter of AI that we're going to have to be dealing with and figuring out how to make it palatable to us. It has some incredibly positive impacts on our lives, and it will have incredibly positive impacts on our lives. And those impacts can be finding cures for diseases that have never been found. Even as we speak, whether it be autism or whether it be cancer or whether it be diabetes or whatever, there are unpublished results that are known to be ready to be thrown out into the marketplace that will impact rural hospitals. Now, the reason this is so important for rural hospitals is it costs money. And for the rural hospitals who are operating with margins of, at best, 0%, to introduce something that's as pervasive as this is a killer for rural hospitals. I can put the numbers to it and can tell you that we could easily lose 6 more hospitals within the year. We could easily lose six more hospitals. I would tell you that between January 1 of this year and today, we have helped hospitals make payroll no less than 6 times. And when I say make payroll, I'm talking about make payroll. I'm talking about, I get a call, others get calls, but I get a call on Monday morning at 10 o'clock and somebody says, I can't make payroll tomorrow. What do we do? And we have to go find sources that we oftentimes know about to help do this. This is a challenge, and we've got to be able to deal with the challenge. We've got to be able to implement AI while at the same time having to deal with the subject matter of cash flow. So as we always say, cash is king, all else is pretty, but cash is king, and this is another occasion that we necessarily have to do that. In order to do that, we've got to have training, we've got to have education, and one of the things that your committee has the capacity to do is to educate people as to what really is needed, and what really is going to be needed is the education of AI and what it will do and can do out in the marketplace. We have developed, just as an FYI, we have developed 2 education programs. And let me back up and say, we are in the education business hometown. Across the nation, we got 20,000 students or something like that are in the world of business office and all of the things that go with it. And we've seen so many things in the business office world that deserve what we're dealing with AI. It's kind of interesting. We can take AI and solve problems that we cannot solve otherwise. For example, we know that there are capabilities out there to solve problems in denial management that we can't get to because of the lack of speed in the processing that goes with it. We know that there are an assortment of different platforms that are available out in the marketplace even today that have been developed in very short order and can deal with AI and all that goes with it. Important that we be able to do that. But we must remember, too, that while we're doing this, there is other technology coming along right behind it, and that other technology that's coming along right behind it is going to smother the technology of AI as we know it. And that technology that we will see coming down the pike is going to be quantum physics. Quantum physics is at the speed of light times the speed of light times the speed of light. It's here, it's happening, and it's being driven by a whole lot of things that are needs that we have to get into that goes with AI. So the impact of AI is a very pervasive concept, but it also is a very pervasive tool with which to work. I did there's a concept called a purveyor in the world, a prompt in the world, and that prompt is a question. There is an industry that is evolving today that is an industry of the question that the prompt asks. There's many, many ways to ask a question, but the most effective way to ask a question is the simplest but most direct. I had the opportunity to be called upon to develop one prompt, and to develop that one prompt, and some people like this and some people may not, but to develop the one prompt just to see what it could do, we chose a section of the state of Georgia that is extraordinarily successful from an employment standpoint, and we did an analysis to see what the longer-term future with that would be. And we asked it the question, what will happen if with 50,000 jobs and the prompt was about a page long. And we did it to test to see what it would do, knowing that it couldn't answer it. We punched send, and after having punched send, we got a result back that told us what's happening in a significant portion of the state, and you just simply would not have imagined what it told us it was happening and would do. Oh, I meant to tell you, it took 10 seconds. 21 pages in 10 seconds. That's what it took, and when we went through and dissected it, it didn't miss. I mean, it told us what was going to happen. That was over on the economic development side. On the healthcare side, you know this, but we're about to see a transition in healthcare, the likes of which we've never imagined. And that transition is going to be healthcare that's going to be, it is what it is. It's going to be driven by the insurance companies. The insurance companies have already embraced and engaged in that process already, and we're having to live with what we see there. We must live with it, but healthcare as we know it, how it is practiced, will not be practiced at all. It will be practiced with AI, and it will be practiced with the concept of digital and what goes with it, and it's going to require a whole new set of thought processes that we've never conceived of. We have to deal with. So be aware, just be knowledge of, and the question is, what do we do? How do we deal with it? I can only tell you from my standpoint what I've attempted to do, and I've read everything I can get my hands on. And when you read it, you get to find out what you're having to deal with. An interesting book, Scary But Smart. The dude in it talked about some interesting things, and he said, you know, when we're dealing with AI, we have to deal with a different concept of principles and things to deal with. For example, one of the biggest, and he was a vice president in one of the large companies. He said, for example, one of the big challenges that I've got is understanding the principles and algorithms of what we're dealing with. For example, we have a situation where we have a soldier in a foxhole, and he's got his gun aimed at the soldier in the other foxhole, and the other foxhole is straight away from him. And the question is then, who's right? They're both aimed at one another, and they're both fighting for the truth. And his question was, what is the truth in the algorithms of AI that we're dealing with? That's what we have to deal with from a healthcare standpoint. As we developed our programs, we have to do those things. A unique thing, we have to have governance. And if we don't have governance in what this is going to deal with and what we'll be dealing with, this governance will be out of control. And when it's out of control, you hear all of the horror stories that can occur when AI gets out of control. It can get out of control in something called regenerative AI and all of this kind of stuff. But we must be aware and we must be assured of what's coming down the pike so we can, at the policy level, know how to deal with it when it comes down the pipe, because it's here. It's not like we can make a decision whether we do or do not want to be involved with it. It's here, and we have to find a way to deal with it. The interesting further thing about this is it has the greatest application, from what we can tell, with that group of people that are a little bit younger than us in this room. And they don't have a problem accepting that kind of change. In this room, we may have a problem with the change. We will be outvoted in pretty short order if we're not already outvoted. We must understand that somebody has got to be sure to be at the front end of the decision-making process, to do fact-finding, to make sure that the fact-finding is relevant, and that we're capable of dealing with it. This whole subject matter of AI is governed by an interesting thing, and the interesting thing is data. We've heard of data. We've heard of data centers. We've heard of all sorts of things. AI has as its birthplace data. And data is all of that stuff out there that we accumulate, whether it be claims processing, from a clinical standpoint, the results. I'm not advocating for it, but I'm just saying somebody drew a conclusion with autism. Somebody's drawing a conclusion with cancer. All of these things are conclusions that are being drawn and being dealt with, and we have to understand where they're coming from and how they can be dealt with. If not, what we end up having to deal with is disinformation. And disinformation in the heart of AI is a killer, so to speak, and we must be prepared to deal with it. Disinformation can have cost us elections. Disinformation can have cost us lives. Disinformation can have cost us the future of a nation. It's all a matter of those people who may have a different mindset than we do about how we live. We've got to step forward. We've got to see how we deal with it. We also must deal with studying those people who are our adversaries. If we don't understand what our adversaries are doing around us, we cannot understand how to survive. And we can be tested in very short order, and it can happen in a much shorter time frame than we'd ever like to think about it. So AI is extremely good. AI is extremely good to the standpoint that you can put a probe Dr. Summers, you can put a probe somewhere out in the field, and AI can, through a telemedicine probe, find a solution out there somewhere. It's happening, even as we speak. We have to decide how we want to accept it and how we want to deal with it when we do accept it. But it's here. It's not going to be long and far and distant in the future, but it's going to be here, and it's going to be in pretty short order. I can go a long ways in talking about this, and I can get very emphatic about what I have seen. If you had seen what I had seen in doing the research that we've done, it would be an extraordinarily unnerving sight to see, because the research that has been done with AI is so far advanced from what the layman knows and understands. It's unbelievable. I mean, it's totally unbelievable. And we're moving into the point where medicine, as we have ever known it, will never be that way again. It is changing it again, the speed of thought. And if you give thinking to that, the speed of thought's pretty big time stuff to have to deal with. So I'll stop at that, but I'll say I encourage you to read. I get up every morning, and I don't advocate this, but I get up every morning, and the first thing I do is I read a news clip that's usually got at least 8 to 10 headlines in it. And of those 8 to 10, I keep a little record of those 8 to 10 headlines that I read. Usually at least half of them are about AI. And if there's that much AI going on and some of that to be read, there's something to be dealt with in terms of what AI is doing. So I encourage you to read, get the books, study the adversaries, know what's going on, be prepared to act on what it is, and make an effort to get us into the future. Also, that one that's in front, if you ever want to get your mind further blown, Google or prompt up those things out there called Google searches and see what's going on out there, because they'll blow your mind when you get, and the thing, you don't have to wait long. The typical response time is probably less than 10, 15 seconds when you hit the prompt. But when you do the prompt and it tells you what it's found, it's done so based on a mountain of data. And if it doesn't necessarily mean that it's right. There's this thing called hallucinations, and hallucinations used to be Halloween. Hallucinations now are with AI and what it does in the marketplace, and you must understand what a hallucination is. A hallucination is a disinformation program that makes you think something's right that's not necessarily right, but you can't prove it and it can't prove it. But it's got it's got the wherewithal to outthink you and outplay you. And if you get tied up into it, as with TikTok and those kind of things, it can be extremely addictive. Medicine, I say again, what's about to happen in medicine is so far beyond the mind's ability to simply think it. It's pretty amazing. Is that bad? Is that good? It can be bad, and it can be good, depending upon whose hands it's in. So I encourage you to read, exercise great care, know that there are hallucinations out there, and that there's disinformation that's going around. I'll be available if you want a question, but thank you for the opportunity to share that thought. Any question? You got a pamphlet there of some stuff that we put together. But,
does anybody have any questions?
Anybody?
Thank you so much.
Thank you.
I also wanted to recognize Chairman Hatchett. He is here today. He is the chairman of appropriations, and we're just thankful to have him. You still, there you are. Thank you so much for being here, and also thank you so much for lunch. Next we have Lori Ott, and she is Executive Director of Georgia Higher Education Healthcare Initiative. Thank you for coming today.
Thank you, Leo. Good afternoon. And thank you, Chairwoman Donatucci, for asking me to present here today. It is an honor to be here, and I'm really delighted that y'all have taken on this seemingly insurmountable problem. I think it's great that we're here at Mercer School of Medicine at Mercer University because Dr. Sumner and her team here at Mercer have been a part of the solution for a long time, and those are the smart people in the room that we should listen to. I also want to say that the earlier presenters, I agree with virtually everything that was said relating to residencies and the cost to train physicians in hospitals. And so I just wanted to say that. So I'm Lori Ott, and I am the Executive Director of the Georgia Higher Education Healthcare Initiative. And Jim Hull and I formed this entity. We've applied for nonprofit status and are waiting on the IRS to give us that designation. But the reason we formed this organization is Mr. Hull has served for 10 years on the Board of Regents. I served 13 years in a hospital, nonprofit healthcare leadership from 2007 until 2023, 2011 until 2023. I was in a hospital during the pandemic. I had literally 12 titles at my time at University Healthcare System, which got purchased by Piedmont and is now called Piedmont Augusta. And I saw the impact of lack of healthcare workforce on the patients, on the families, on the staff, and on the providers. And so Mr. Hull and I have formed this organization to see what we could do to measurably impact the number of physicians we have in the state of Georgia, eventually the number of nurses. Before I left Piedmont Augusta, I put together a training and employment program to grow the number of associate degree nurses graduated from a local technical college and raised $1.5 million in scholarship dollars for that program. And they will quintuple the number of nurses graduating from that program. That is a drop in the bucket when you're looking at healthcare providers in the state and the number of nurses needed. But today we're going to talk about physicians. I'm going to go kind of fast because this is just background information. The problem of physicians in the United States is not a Georgia problem. We are struggling. We are in the bottom quintile for physicians per capita, but I think everybody in the room knows this is a national problem. These are just some statistics as they relate to internal medicine. These are HRSA statistics, so Health Resources and Services Administration projections. So the United States is not meeting the demand. The United States number is the 87%. The United States is not meeting the demand. Georgia's number is in red. Georgia's only meeting 85% of the demand for internal medicine physicians. Metro areas, that's national numbers. Metro United States is meeting 88% of the demand. You can see the rest of the United States, non-metro areas, these are population points of 50,000 or less, only 46% are meeting the demand for internal medicine. So I show you that to say that this is not just a Georgia problem, it is a national problem. That was 2025 projections. If you look out into the future to 2037, it gets worse. And so unless we take really serious actions, the United States faces an internal medicine demand, and Georgia's demand goes from meeting 85% of that demand to meeting 79% of that demand. This is the actual numbers of physicians that Georgia needs, internal medicine physicians. If you look at 2025, that's where we're meeting the 83% of the demand, or I'm sorry, 85% of the demand. If you project out to 2037, we will have 2840 and we will need 3,600. So that's 760 physicians short. That's internal medicine only. And again, stepping back from the highest level, the 30,000-foot view, Georgia's projected shortage of all physicians will be about 8,000. Chairman Parrish knows this number because I've talked his ear off about it, but we need in Georgia, just to be average, just to meet the national per capita 185 physicians, just to meet the national average. And I don't think anybody in this room woke up and said, gee, we'd love just to be average. You know, if we're going to be a top 5 state for population, the #1 state to do business, we want to be better than average. And these are the health profession shortage areas in Georgia, and those who have poor access to providers, and internal medicine access, as you all know, is especially limited. So why the shortage? I feel like other speakers have done a great job addressing this. The aging population of physicians is one issue. Baby boomer physicians worked long hours and work long hours. I know this because if I was ever at my old hospital 11 o'clock at night, there would be boomer physicians in the cafeteria running through to get an ice cream sandwich on their way to go round on their patients at 11 o'clock at night. So these boomer physicians are aging out of the workforce or getting older, and they do work longer hours and had less work-life balance than this younger population of physicians. I do want to say also that, Dean Sumner, I agree that pathway is a much better word than pipeline because people don't fit in pipes, they fit on paths, but here I did use the word pipeline. So the training pipeline in Georgia is insufficient. And I've heard a lot of people make reference to these numbers today. 2 out of 3 Georgia medical school graduates, and that's all 5 of our medical schools averaged together, 2 out of 3 Georgia medical school graduates leave the state for residency. They leave the state to go get their residency training. That number is too high, and I'm going to talk a little bit about that. If they leave the state, if I graduate from Mercer and I leave the state or any of the other medical schools, and I only did my medical school in the state, 43% of the time I will return after I did my residency. These are numbers from the AAMC. I heard somebody else, I think, say that they were at the AAMC conference in January. I think that was Dr. Hanna before. If I come into the state to do my residency, and that could be from anywhere, it could be from Florida, South Carolina, Detroit. If I come in to do my residency, I pretty much like it here in Georgia, and 49% of the time I stay. By the way, that's a pretty high ranking for Georgia. We rank 16th or 17th in the nation for being able to keep physicians who come here for residency. Now, the winner here is if I do both my medical school and my residency here in Georgia, and that number is actually 73.1% in the AAMC data. So if I go to medical school, residency, 73.1% of the time I will stay in Georgia to practice medicine. So let's talk about those residency programs that we have in Georgia. Of the 306 internal medicine residency positions that were offered in the 2025 match, which was just filled, all those residents started July 1st, 293 were filled. So 306 were offered, 293 were filled. I want you to focus on this number. And this number is available on the ACGME website. I heard somebody else today mention the ACGME. That's the Accrediting Council for Graduate Medical Education. Georgia today has 74 ACGME residency positions in internal medicine alone that are not filled. And they are not filled mostly for the reason that there's no funding for those residency positions. That opens up the can of worms that we want to talk about residency funding. There are 2 big buckets of federal support for residency funding. One is Medicare and one is Medicaid. Medicare is bigger than Medicaid. But the reason that most of those 74 are not filled, there's some onesie-twosies. There's a J-1 visa. The committee has access to all the rationale that hospitals gave us for why those residencies aren't filled. And some people may not, they may start a program, they may drop out, so those numbers fluctuate, but all this data is straight off the ACGME website. We do have total in Georgia 497 approved residency positions that are not filled. Of those, that 74 are internal medicine. So as we look on the horizon, how might we begin to solve this problem? One thing for sure is to fill the residency positions that are approved by ACGME, which is the accrediting body for those graduate medical education. No hospital or teaching facility can get paid by the federal government unless you have that ACGME approval. So we've got 74 that are out there that are vacant, approved, simply not filled. And I hope there's lots of questions about those. So then you're asking, like, where the heck are these? You have this in your packet. The reason they're highlighted in yellow is on my spreadsheet where I track these, hand-pulled off the ACGME website. This is what Georgia considers a core residency. You know, those are emergency medicine, family medicine, internal medicine is one of those, OB-GYN, general surgery, psych, and peds. I think I got those right, Dr. Sumner. If I got those wrong, you're going to correct me. These are the facilities, the location, the year that they were started, and then we checked this website July 23rd. So this is current. There may be one person that dropped in or dropped out, but those are the filled. You can see the filled is the second column from the right, the approved ACGME, and then the difference. And again, Of the 991 total approved positions for internal medicine, 919 are filled, so we have 74 vacant. Solutions in motion. As you all know, there are already folks working on this, and they've done an incredible job. The Medical College of Georgia has an Archbold partnership for internal medicine. As Dr. Lyon very well articulated, there are telemedicine programs for rural counties and rural hospitals. There are incentives to practice in underserved areas. Mercer is a great example of that with your service scholarships, the Nathan Deal scholarships. Dr. Odom had a question about loan repayments through the Georgia Board of Healthcare Workforce. And then there are other incentives prioritizing in-state and rural background graduates. Solutions for consideration for this committee: fill those existing 74 vacant ACGME approved residency slots. That would be locating funding sources for that, and I can talk about that in a second. Establishing a residency quality improvement group for best practice sharing. This is something that, that our organization, Georgia Higher Education Healthcare Initiative, submitted to the Rural Health Transformation Program that the One Big Beautiful Bill, now called Tax Cuts for Middle Class Families. President Trump's administration has announced $50 billion in funding to transform rural health. One thing that we called for in that call for proposals from DCH was to establish a council or a sharing group to share information about how to improve the quality. So it's about the quantity of residencies, it's also about the quality of residencies. So we called for a quality improvement group. Something that Dr. Sumner and I agree on, and this was just an aside, is rural practitioners have just as much, if not more, to teach urban practitioners and then vice versa. So there's a lot of good sharing that can go on by forming that kind of council. And then expanding and filling new residency slots, especially in rural communities. In that Rural Health Transformation Program grant, we did suggest that part of that $100 million a year go to fund rural graduate medical education. And find ways to incentivize folks to go to rural parts of the state through increasing scholarships, loan repayments, and incentives for new physicians. I heard this committee's conversation about what kinds of stipends, what kinds of housing allowances. Chairman Parrish and I traveled to Miami Miller School of Medicine at the University of Miami. Feels like 10 years ago, Chairman, but I think it was just in 2024, if I'm not mistaken. And we learned that Jackson Health in Miami pays a $60,000 a year stipend to their residents to incent them to stay after they complete their residency program. They pay $5,000 a month, and it doesn't conflict with any federal policies. That's just a stipend that that hospital pays in order to keep them on after they complete their residency. The last thing I want to say is it's not just about the funding. So we do have a quantity problem of residencies in Georgia. We need 1,007 residencies filled to catch North Carolina. We need 1,782 to be average. And I know I'm throwing a lot of numbers out at everybody. If we wanted to be top 5 in the United States for graduate medical education filled slots per capita, we'd have to add 5,000 slots. And I see Dr. Odom looking at me, and he just made a face that makes me understand that he thinks, that's crazy, that's a lot. Tomorrow we could not add 5,000 slots, but a journey of 1,000 miles begins with a single step. How do we get more residency positions opened? How do we get them filled? And then how do we build on that and build on that success? We know where 497 openings are. We know where 74 residency slots in internal medicine are. Can we attack it with the funding? So this is FACT, F-A-C-T, because it's easy for me to remember. F is the funding, so finding the funding to add those residency positions. A is admissions, and I think this is something that we could all learn from Mercer on. Admitting folks to medical school. If we want to fill counties with rural counties with physicians, admissions panels in all Georgia medical schools must look to recruiting from rural counties. And that's a pathway and a pipeline that Mercer is actively working on. AHEC, The area health education centers is also looking at that and doing medical school summers and those kinds of strategies to attract people from rural areas, and how to prepare and make those students ready to be successful in medical school. So admission strategies is the A. C is contractual arrangements, and this gets to what Dr. Odom was asking, which is how much are the incentives to put a physician in a rural area, and are they enough? It's my understanding that the Georgia Board of Healthcare Workforce loan repayment program, that they offered more slots than they filled. And the question is that amount of money enough to attract someone to a rural area? Again, backing all the way up to the Mercer question, which is about admissions, it's much easier to get somebody to go to a rural area if they come from a rural area, but if they don't come from a rural area, if someone comes from out of state, how do you attract them to a rural community? One of those incentives would be loan repayment programs. The Georgia Board of Healthcare Workforce did cease its scholarship program. I think in 2016 was the last time that they offered that. I think they rotated and had the last few folks who had received those in the last couple of years. And then T is training culture. How are we talking about ourselves as Georgians? As students graduate from Georgia medical schools, are we talking about opportunities to train in Georgia as if we are good? Is our training culture good? Do we see ourselves as having quality programs? And what are we telling students who graduate from Georgia medical schools? And are we pulling anybody aside to say, you know, that Johns Hopkins is pretty great. You know, that Mayo, that Cleveland Clinic. How do we improve the quality of our training culture? And then how do we improve how we talk about opportunities to train in Georgia? So those are that's just sort of the outline of it. These are our data sources. All of this is available on our website, which I have put on the last page, I think. We also have a data dashboard on our website if anybody would like to look at it. Everything from riveting hospital cost reports as it relates to graduate medical education to where Georgia ranks per capita compared to other states, to where we rank per capita physicians. I do also have some nursing data on there, as well as a map locator of where these vacant internal medicine GME slots are located. And with that, Madam Chair, I hope I gave you a couple of minutes back, and I would be happy to take any questions if there are any.
Do we have any questions?
You can call me later. That's why my cell phone is up there. And okay, I do want to say that there's a pseudo complexity related to graduate medical education. I think what we have identified is that best practices in other states are happening, and Georgia can learn a lot from those other states. And I think anybody who says this is too difficult to understand, the question is how do you get hospitals to engage in teaching more residents? There's a cost to that. I thought the president from the Coffee County Hospital did a great job outlining that to you all. You know, deciding, do I launch a GME program or do I make payroll? Do I cut a service or do I launch a GME program? That's where state support for graduate medical education can most certainly come into play. So there's the cost question, and then there's the benefit question. You know, if you train residents in your hospital, they generate charges under the attending. The really great thing is they generate care. They generate care. They generate care for people who need to be seen by physicians. Yes, they are training at the same time. Yes, they are supervised by attendings and faculty, but they generate care. And that's clearly what Georgia needs.
Representative Osteen.
I thank you so much, Madam Chair. I think that maybe you've answered the question, but when looking at this slide here, I just was looking, and there are 4 counties. It's the internal medicine residencies in Georgia. There are 4 counties south of Macon for the entire breadth and depth of the state that have internal medicine residencies in Georgia. And I assume the reason for that, and I know that my hospital, Coffee Regional, is coming on board starting next year, but I'm assuming the reason is strictly it's cost prohibitive for the hospitals to do it. Is that why we don't have very many places for students to train?
That's such a great question. I appreciate that, Representative Osteen. Historically, Georgia has had fewer residency sites than the Northeast and the Midwest. I'd have to take you back to 1997 when Congress froze graduate medical education funded by Medicare. That was done, and hospitals were frozen at 1996 levels. And so regardless of how many people we had in Georgia, and this really applies to the South and the West, we all got frozen at what we had in 1996, all the states. And so the states that were populous and had well-developed residency programs got to keep what they had, and it became more challenging to add to what you already had. And so that's on the Medicare side. That's why so many states have looked to Medicaid to fund additional residency slots. And these are two different things. This has nothing to do with Medicaid expansion. I should probably say that about 7 times. It has nothing to do with Medicaid expansion. But so whatever we traditionally had, it's been challenging, other than adding residencies like St. Joe's Candler and other places that are Medicare naive facilities. Every once in a while you'll hear somebody say, well, that's a GME naive hospital. That doesn't mean they don't know what they're doing. It means that they've just never had Medicare funded residency slots. Those places can add Medicare funded residency slots. Those are opportunities for hospitals. Some barriers to that, I just want to anticipate the question, like, why aren't we doing more of that? I thought the president of Coffee County, Vicki Lewis, I thought she did a great job outlining it, which is sometimes it can be difficult unless you have a great faculty member who can come over and step into the role. It's hard to develop from scratch a program, especially in a rural county, especially in a place that already has a shortage of physicians. And this is where sharing programs, having faculty from medical schools, is there somebody from a county that wants to retire to that county and continue teaching? You know, what are the creative solutions to get someone to come into a hospital and teach? And then how do you partner with maybe facilities that have a more robust faculty? You know, there are some hospitals that do have a robust faculty. How do you partner rural with non-rural facilities? And how do you get those folks who are training in urban areas to go to rural areas to train? Because they're more likely to practice if they go someplace where they've had a rural experience. Some of that's stipends, some of that's faculty incentives, other things like that.
So what I think I hear you saying is that it would behoove this committee and the General Assembly to figure out how to incentivize, as Chairman Parrish said, these rural students to come back and practice in rural Georgia, to make life more affordable while they're doing their residencies. Is that what I hear you saying? That
100%, yes,
okay.
Absolutely, Representative, and especially as a tactic, right? I mean, that's why I put the FACT together. You know, any one thing, you could get results from any one thing, but can we look at this from a strategic standpoint? And can Georgia be strategic when it comes to developing and rolling out additional training slots? Instead of operating in silos, how do you get more cooperation? How do you get more looking at the big picture? And then there'll be local solutions. I mean, you know, the example in coffee is a great example of a motivated CEO. I pray for her. You know, we really pray that she is extremely successful, because that's going to be a workforce, you know, it will. And then those folks could turn around and train the next generation. Yes?
On this data, with the unfilled spots, a few that I know about that are unfilled. Okay. I forget I have to talk to them, sorry. So if, for example, isn't Piedmont the medicine residency in Athens, it's a fairly new residency?
Yeah, that was started, Piedmont Athens was started in 2015 through the GREAT Committee.
But it takes 3 years, and that one's older than that, but it takes 3 years to fill the residency. Like, I think Atrium, which is our residency, I mean, those guys work for me, so Atrium just expanded their numbers, so they had a first-year class, but they can't fill the second and third-year levels.
That's right.
They have to move up the chain.
That's right, yeah. So if you're approved for 3 a year, and so that you'd be approved for 9 total, and you would, as you fill up your program. Not all of these, though, that are vacant are new programs. The Archbold program in Thomasville is a fairly new program. They matched 20 residents but struggled to fill the other 4 slots due to recruitment interest issues. So that would be another place to ask, how do we incent folks to fill those slots? The rest of them are really not that new. St. Francis,
But the federal
Emory,
government
Columbus
came
is here.
back a
They're
year
filled.
or two and expanded them. So they had 10 forever, and now they have 12. So it takes, when they add those extra 2 or 3,
right,
it takes a few years to get it up to okay. I mean,
right,
up to full.
Right.
But they're essentially full.
Yes, ma'am. Yes, Dean Sumner, so of the 497 total unfilled slots across Georgia, the 74 internal medicine, which we have drill down on, not every single one of those is not filled because of funding, but funding is the biggest reason they haven't filled them. And if anybody wants to talk about Medicaid and using Medicaid for graduate medical education, that is a really fascinating topic. We can look to other states and where Georgia ranks in terms of leveraging those dollars to train physicians.
Chairman Parrish.
Thank you. We've had some good discussion today, and I think all of you members of the House here can feel good that you voted for and helped Chairman Hatchett put $20 million in the budget last year to assist those who wanted to start new programs. And the program down in Savannah at St. Joe Candler is just such a program that's going to really change the complexity of that part of the state. As you all know, that they did not have a program, so it'll be a naive program, and they'll start with a lower number, but they'll be adding, and for the first 5 years, they can add to that and not get over their cap that's Medicare approved so that they can draw down the federal dollars. But we also put money in the budget to help other hospitals around the state who wanted to add a residency program, maybe that were just starting one. It was startup money to help them get started with that. And you're right, it's an expensive proposition, and it's going to cost a lot of money. We need more slots